Raghav Seth to share his toughest 3 cases.
So good morning everyone. I am Dr. Raghav Seth and I'll be discussing a few challenging ablation cases. So not exactly challenging but cases with few learning points. So first case is of thyroid ablation, and why was it difficult or why was it special or different? Because the nodule was extremely hypervascular, and in what we can do in these cases, I am going to demonstrate that. So basically this animation is just to show you that, let me switch on the laser point, yes. So that we can, in a normal thyroid nodule, we can ablate it either via transisthmic or lateral approach. Both are feasible. Transisthmic is considered as if you are starting with the thyroid ablation, the medial approach or transisthmic approach is preferred to be done. Then is the, after that we talk about the, that is the moving shot technique. So we have to keep the microwave ablation antenna at or RFA, whatever we are using, at a certain point, and for 10 seconds we keep it there and then we move it roughly around 1 centimeter, because that is around the ablation zone that is created during that time. We have to be very careful about the danger triangle, of course, to preserve the recurrent laryngeal nerve, and in 4 to 6 weeks mostly the involution or the necrosis, ischemic necrosis takes place, which reduces the size of the nodule. So we have discussed about this as well, and of course we need hydrodissection so that we can protect the critical structures of the danger triangle. Now just demonstrating this hydrodissection. So hydrodissection is mostly done from the lateral aspect, and what we have to achieve in this is, so what we have to achieve in this is to completely hydrodissect the thyroid from the rest of the structures, especially posteriorly. So if we see in the later part of this video, we will be able to see that I am trying to hydrodissect it so that the fluid is going even up till the posterior most aspect. Now this was all the routine thyroid ablation that we do in all kinds of nodules, but just wanted to introduce about vascular ablation techniques which are relatively new in this scenario. So when the nodule is very hypervascular, if we are doing RFA, the problem is of heat sink effect, which can lead to incomplete ablation. Of course, that is one risk. Another point is that hemorrhage and perinodular hemorrhage, swelling, all those things can occur. So two techniques for vascular ablation are artery first and marginal venous. Of course, we have to ablate the artery first, because if we do the venous first, then it will lead to edema, because there is no outflow. So in these vascular ablation techniques, what we are trying to do is we are directly ablating the vessel itself. So as I have already discussed these points, so this is how it is basically done. So before starting the ablation, that is after hydrodissection, this microwave antenna, which you can see here, is actually, I just entered it, and the main feeding artery or main artery which we can visualize is directly ablated. That is the arterial first ablation. Next is the, so this is just how do we notice that, or how do we observe that? So the micro bubbles or the linear echogenicities which we see, they will spread throughout the nodule. After that comes the marginal venous ablation, which is simply that the rim of these vessels, veins which we see in the periphery of the nodule, are also again directly ablated. So again in these videos you can just observe that this is the antenna which is in the third video. So this is the antenna which is coming here, and I am ablating the marginal veins, so we can again see those air microbubbles flowing throughout, and then we can carry forward with the rest of the ablation. So this is just the pre and post images of this patient. So the take home message is that just a new kind of technique of vascular ablation which we can employ, artery first and marginal venous, in extremely hypervascular nodules. So very briefly and quickly moving on to the next part, that is the parathyroid nodule ablation, parathyroid adenoma rather. And the special part was that of the location. So it was a retropharyngeal, retroesophageal parathyroid adenoma with a very difficult location. So the routine RFA, we use RFA in parathyroid adenoma ablation, 19 gauge antenna, hydrodissection, again everything routine. But so this is before starting with the case, I just wanted to show you that how we usually do this RFA. Single shot RFA is enough for a smaller nodule, and for larger nodules we can just use the moving shot technique just like thyroid nodules. Technical endpoint is echogenic cloud covering the complete nodule. So in this case the question was about the location. So it was a very rare location, that was retroesophageal. Also unconventional access had to be taken. So we had to follow a complex transthyroidal approach instead of the lateral approach. Also it was very close to recurrent laryngeal nerve, so risk of nerve palsy was there. So real-time voice monitoring was done, continuous hydrodissection of course. So we asked the patient for active phonation throughout the procedure so that we can make sure whether the heat is not being transmitted to the nerve. So clinical presentation, specifically this patient had classical features of primary hyperparathyroidism with even the biochemical markers predictive and showing primary hyperparathyroidism. So this was the nodule here, which was quite atypical in location and difficult location as I mentioned. So why not surgery? Again same the points which support ablation, so high surgical anesthesia risk, escalated complication profile, and the patient himself wanted for minimally invasive procedure like ablation. So these were the planning that we performed, specifically the route of our ablation and also the monitoring of heat. So after hydrodissection, we just went through the transthyroidal route instead of the lateral route in this case, and used the moving shot technique to ablate this parathyroid nodule. Within few hours we can see the change in the parathormone, serum PTH, this was at 24 hours, and of course serum calcium and other parameters also normalized within 24 to 48 hours. So there was no complication, same day discharge, pain was controlled, and at 3 months follow-up, the volume reduction rate was more than 90%, and since biochemical cure is there, so we don't actually need more. So the main take-home message will be, yes, if the nodule or parathyroid adenoma is in a danger zone, we need to plan it with hydrodissection, active neural monitoring, as well as for different approach techniques depending on the case. Finally, quickly moving on to the third case, that is the spinal osteoid. So again, this case is special because of the proximity to the spinal cord. So it was few millimeters away, just almost touching the spinal cord. Young patient, risk of permanent motor sensory deficit, so there was no margin of error. So this was a 24-year-old female, and Viwas score was 10/10. The lamina of the D11 vertebral body, I'll just show you in the subsequent slides. There was an 8 mm nidus, that was the osteoid. So this is the lesion here in the lamina and just abutting the spinal cord. So we had to plan what is the ideal approach and how to proceed with this. Distance, as I mentioned, was 5 mm only. So we planned for a complex dual access, that is simultaneously we will with ablation we will place the ablation antenna is of course 16 gauge, 14 gauge, whatever you want to use. Along with that, a 22 gauge epidural needle via the interlamellar approach at the same level, and then we injected air. Again in this case, the ideal scenario to use is carbon dioxide to decrease the risk of air embolism, but that was not available, so we had to go forward with air. Also thermocouples are now available, but at the time when we did this case, it was again not available in our institution. So the only protective mechanism which we had was to inject the epidural air at this level and look for the air cuff again and again by repeating the CT sections while we are doing the ablation. So that was the insulation technique, and this was the post-procedure outcome. We can see this ablation tract here and the air still being there, confirming that yes, the protective epidural cuff is there. So at day 1 only the VAS score reduced to 0 completely, no sensory, no motor deficits, and the patient is still on follow-up. So again, a good case with so the learning points include that atypical locations just like this, who are the nodules which are very, very close to the critical structures or like spinal cord in this case, we can follow air insulation techniques. If we get another case similar to this in future, definitely we will be using the thermocouples and CO2 instead of air to reduce the risk. So thank you. This is my team at Gangaram Hospital, and any questions will be welcome. Thank you for your patient hearing.
So after this great talk by Dr. Raghav said, we then move to challenges in liver ablation. Please welcome Dr. Dhruva Upad.
Morning, everyone. That's quite a good turnout for the first session after gala dinner. That's pretty good. Thank you for turning up. My name is Dhruv Patel. I'm one of the interventional radiologists in Queensland, Australia, and I'm going to talk about the challenges in liver ablation. Mainly, obviously, the technique part. There are wonderful talks about challenging and difficult cases, so I'm going to leave the technique part out, but I'll talk about the rest of it, as in how to set up the MDT and defining what are the other challenges, like the non-technical challenges, setting up the liver ablation. And to be honest, that applies to any other type of ablation at your institute. So when I trained initially at Westmead Hospital in Sydney. That's about 1,000-bed hospital, and then I went on to Cleveland Clinic in US. Came back to Australia and currently working in Royal Brisbane and Sunshine Coast, 2 tertiary hospitals. And I thought that's a pretty good setup to work, a lot of help. And this was my first case, first day as a consultant. A patient, a young 20-year-old was bleeding from the shoulder neurofibroma, and there were 6 consultants, 2 anesthetists, vascular surgeons, all trying to do whatever we can. And I hope the purpose for these images was just to wake everybody up, hopefully. This chap actually was sipping coffee 1 week later in the cafeteria of the hospital, so we were pretty happy with that. Anyway, going on to the first challenge, that's setting up the local MDT and defining the role of your microablation. We already talked about the flowchart of the BCLC and the policy setting up 2 days ago at the panel discussion, but essentially early stage, very early stage, that's when the ablation has the role, and it has been shown to have a pretty good outcome, almost as same as the surgical resections in certain scenarios. So at our institute, we go for ablation. Sorry, let me go back. If the surgery is possible for BCLC-A and Child-Pugh, like early liver disease, well compensated, good ECOG status, those patients will go for the resection. Surgeons will be very keen to go ahead. Having said that, though, most of the liver patients are not very suitable for surgery. They actually are advanced liver disease by the time they come to us. So then ablation, more common than, actually probably 80% of the patients end up having ablation rather than resection in our setting. How do we set up the MDT? So I have been actually very lucky to work at places where MDT was already set up, and I didn't have to do any hard work. But I can imagine how difficult it can be to bring everybody together in one room and regularly and have a consensus amongst themselves to tackle the liver HCC or any other liver metastatic disease. Particularly if you already don't have it, in different part of the world, I've seen it's difficult to set it up, especially in the private healthcare setup. And we actually allow our private hepatologists to attend the MDT just to help those patients who they see privately outside of the public healthcare system. From our perspective, what an interventional radiologist can do to help the MDT setup, I just tell everybody, especially my juniors, to try and be a problem solver for the clinicians. They will call you, they will contact you anytime, even if you are away. You want to build a relationship. You want to create a good rapport with them so that they will trust you, but they will also, they know that even if this person is not available in the hospital, I can contact them and they will, if they don't have the answer, they will find the answer. If they're not physically present, they will find somebody who's physically present and help them. And that's what I like to do. Even yesterday, I received a call from one of my colleagues, and I tried my best to help out. What will happen eventually is once you gather the hepatologist or the medical oncologist, radiation oncologist, and if somebody is not attending the meeting regularly, but they will realize that this is going on, and they will attend out of FOMO, fear of missing out. Because obviously everybody wants to receive, everybody wants to contribute and receive the patients from the other specialists, and vice versa. And eventually, once you have the setup, they will, if somebody is not part of your team, they will be keen to be part of your team. And yes, local policy setup, I pretty much touched base on that 2 minutes ago, so I'll skip on to that. But one thing I would like to say is be aware of the latest literature, not only in IR journals, but also literature from the surgical journals or oncology journals, because quite often in the meetings, they throw some numbers or literature at you, and you, if you are aware, you can actually indulge into the discussion, scientific discussion, and answer their questions or answer their queries, and you can discuss with your knowledge that, yes, sure, your articles or your literature has shown this, but this is what we have seen on our side as well. Or if there could be some limitations on their side, we can highlight those. So in terms of the literature for ablation, there are several articles that are quite useful that I found recently, comparing the surgery and the ablation in HCC, some randomized control trial. There is, as we discussed a couple of days ago, there's good literature out there comparing both of those ablations and the surgery. And to be honest, they're both pretty similar. But however, I do agree that patients who are suitable for surgery, resection has a better long-term outcome or overall survival compared to ablation alone. All right, so that's challenge number 3. So we've set up the MDT, you are well versed with your literature, you decide in the MDT that this patient is going to go for ablation rather than resection. Great. So now, on the day of procedure, what's going to be your weapon? Do you want to use radiofrequency ablation? Do you want to use microwave ablation or cryoablation? And the other option is IRE. IRE has not really picked up, at least where I worked, compared to the theoretical potential that we saw a few years ago. Having spoken to some seniors who've tried that before, they say they didn't really quite like it because of the technical challenges. I've never used myself. But yes, and also I have not used radiofrequency because by the time I started training, all the centers had already moved on to microwave ablation. So let's ask Mr. Arnold, does he like radiofrequency? Does he like microwave or radiofrequency? Or sometimes he will feel like I want to use multiple needles. So he pulls out a big gun, cryoablation. But as long as, to be honest, I've spoken to multiple people, and the impression that I get is that as long as you are comfortable with the weapon that you like, you will be a happy person. Because the results, your outcome, I always believe that the outcome depends on the operator experience and comfort with the device that they have. If you give me an RF ablation, my results not going to be as good as with microwave ablation. So if you are comfortable with RF ablation, that's still a good option to choose, knowing that there are some limitations. What are the limitations? There was a wonderful article in 2009 from Dr. Chris Brace, and he actually did lab experiments, animal experiments, and he found out that the microwave ablation achieves rapid temperature growth and also higher temperature with a better heat dispersion within the tissue parenchyma. And he actually used, those probes on animal models. So this is a pig lung, single probe RFA on the left-hand side versus single, you can't see the cursor, but on the left-hand side we have the single probe RFA versus single probe microwave, and you can see the ablation zone is much larger than the RFA. Similarly, same result in the kidney ablation as well. And this is the liver. He used 3 probes around the vessels, And he showed on the left side, you can see because of the heat sink effect, the RF ablation zone is affected more than the microwave ablation, although I'm not sure why he didn't place the third needle on the other side of the vessel. However, number of studies have actually shown that the heat sink effect is less affected by microwave because of the better heat dispersion. And then we are talking about, so yeah, these are the studies that have actually compared. This is a meta-analysis of 7 studies, including RCTs, and they have shown, so in the clinical life, these studies have shown that the microwave offers superior control and the local tumor progression compared to RF ablation. All right, so then we have decided that, okay, microwave, sure, that's what I like. Then comes new kid in the town around the block is cryoablation. What do you want to do? Do you use cryo? Do you use microwave? Look, we use both, and both modalities have pros and cons. And every now and then we will pull out one gun or the other gun. But this was another article published in 2024 by Dr. D'Souza, and the team actually very nicely described the differences and the role of cryoablation in the liver. Unfortunately, there's not much there's not much RCT evidence to date, and so we are relying on the retrospective data that we have. And this is another meta-analysis of the retrospective studies from China. And both these studies have basically said that the outcome between the microwave and the cryoablation is quite comparable for the lower tumor progression as well as overall survival. But the cryo has a better safety profile. But that doesn't mean we use cryo for every case, because there are certain cons of using cryo. So what are the advantages of using cryoablation? Well, size. Microwave, what we do is at our institute, we would use microwave for up to 3 centimeters. Maybe you can push your limit up to 3.5. But beyond that, we would be very, very cautious of using microwave because we have cryo available, so why not use that? The other big advantage of cryoablation is location. It is safer at certain locations, including around gallbladder, stomach, bowel. Bowel, questionable, but I try to hydrodissect the bowel away. I don't take a risk with bowel, but gallbladder, certainly we have, stomach we find. Capsule, liver capsule is much better tolerated. If your ablation zone is going to be near the liver capsule or the diaphragm, cryo is much better tolerated than microwave, in my experience. But what are the downsides? Another advantage of cryo compared to microwave is the immune response. So cryoablation basically releases the tumor antigen into the bloodstream, and that basically starts the immune reaction from the body itself and acts as a immunotherapy to a certain degree, which doesn't happen in microwave or radiofrequency ablation because it basically denatures the tissue or tumor protein rather than releasing it in the blood or rather than causing the cell death. What are the downsides of the cryo? Of course, cost, because it needs multiple needles and the needles are expensive. The other issue is you are reliant on the availability of argon gas. For those who have done cryoablation, you know that's always a question halfway through your procedure or before the procedure. You have to make sure the enough argon gas is available. I remember we used 4-needle cryoablation in a case. I have an image coming up. And 4 needle, but we had to do 2 burns, so pull back and do another freeze. So in that case, we were constantly looking at the monitor of the cylinders. How much gas do we have? Are we going to run out? Luckily, we didn't, but that's a problem. Especially your logistics team have to be very switched on to make sure when you have a case that argon gas, the needles, and everything is available. The other problem with cryo is the longer freeze-thaw cycle. Commonly for liver, it's an 8-minute freeze, 5-minute thaw, 8-minute freeze, 5-minute passive thaw, and then 1 or 2 minutes of active thaw. So altogether, your ablation itself takes more than half an hour or close to 45 minutes. And imagine if you are doing 2 freezes, pulling back and doing another one, almost more than 1 hour is just for the ablation part itself, excluding the needle positioning part and anesthesia time. The other issue that we have personally encountered at our institute is the biliary stricture after the ablations, but especially in the central lesions and the larger lesions. Literature says doesn't make any difference compared to microwave, but that's not our experience. We probably see more than 50% of larger central lesions with biliary stricture eventually after the ablation, few months after the ablation. So this is one case where you can see the lesion is abutting the gallbladder pretty close, and also the capsule. The hepatic flexure is also close by, but we managed to navigate in a way that we were not worried about that. We did use hydrodissection just to push it away. Unfortunately, I actually couldn't get the image of the needle placement, but this was the 3 or 6 month follow-up. You can see the tumor, the original tumor was all ablated, but then there was a local tumor recurrence, exactly at just touching the fundus of the gallbladder. So we went back again with a single needle cryo, right next to the gallbladder, right next to the capsule. We pushed the bowel away with hydrodissection and did another ablation. And this is 6 month follow-up after that. There's no recurrence, it's fine, and gallbladder has taken the hit very, very gracefully. No post-ablation cholecystitis. Another case, this is a larger lesion. So this patient actually is a bit tricky one in the sense that he had cardiac issues, and initial CT showed a lesion which was 3.9 or 4 centimeters, and so we decided to go with cryoablation from beginning. But by the time he sorted out his cardiac issues and came to us, took almost 2 months. And on the day of procedure, the lesion was close to 4.5 or 4.8 centimeters. 4.8 centimeters or so. We still went ahead, ablated with 4 needles, and I had to pull back, did another freeze, and I was worried about cryo shock. Didn't see it, luckily it was fine. These are the follow-up images. You can see the tumor is well treated, no viable tissue on subsequent follow-up imaging, but this is almost 9 month post-ablation, what I wanted to highlight here is the biliary obstruction. You can see on the coronal plane and also, so both coronal plane images, but one in the posterior segment and one the segment 8, the bile ducts are all tapering into that location of ablation. So almost certainly this is because of the ablation itself. Patient didn't have real issues with that. Bilirubin was slightly up but remained stable on subsequent follow-up, and we luckily didn't have cholangitis, but unfortunately had metastatic disease. Eventually got palliated because of the metastatic disease to bones everywhere. And that actually takes us back to the original question of tumor biology. Most of the HCCs, we don't know the tumor biology, how aggressive it is. But here, because we knew that it had grown almost by a centimeter within 2 or 3 months, we knew it's going to be aggressive biology. And the outcome actually is...
Sir, we are on shortage of time. If you can quickly
Yes,
wrap
I'm almost
up.
finished here. Thank you, thank you. And limitations, you need to be aware of the limitations of ablation: size, location, resource availability. Obviously, certain locations you are worried about on the left side, close to the heart. Not that you cannot do, but initially I wouldn't pick up on those cases, and pretty much same thing. You can push the limits, but not initially. Once you get comfortable with those different modalities, then you can think about pushing your limits to a certain degree, especially after your MDT is on board with you. And with that, I would like to conclude this talk, and I would like to invite you all to IRSA, which is the Australian version of ISVIR, in July, and that's also in Brisbane this year. Thank you so much. Thanks, everybody.
Returning to the challenging cases experience, I invite Dr. Kunal Gala for my toughest 3 cases.
Good morning, everyone. First of all, I would thank the organizers for inviting me to deliver this talk of 3 difficult cases, and it was actually difficult to choose which one shall I start with. So there were a couple of head and neck ablations which are pretty much unusual. That does not come a long way, and that's why I have chosen a couple of head and neck and one MSK tumor. So basically this was a 13-year-old kid who had a left CP angle mass, and he was already radiated once. And he was operated once and had so it turned out to be left CP angle schwannoma. Currently he had deviation of tongue, had multiple episodes of seizures, and he had skin nodules, cafe au lait spots. So basically it was NF, neurofibromatosis. And post-operatively there was some residual lesion, recurrent lesion, and in MRI it was showing intraaxial and extraaxial component. So what we can see here was intraaxial and extraaxial component. So basically, since the patient was already operated, there was already radiation given, so surgery was very difficult, one. Second, re-radiation would be a challenge in a kid. So they told us that can we do cryoablation. So what we did was we did cryoablation. So initially we tackled the extraaxial component, thinking that the intracranial portion may be at the second stage we can do a stage cryoablation, and this is what extracranial component. So this was extracranial component which was cryoablated with ice cure, since that was the only available maybe maybe one year back. So that was it, and this is what was the approach which was taken for anteriorly and going laterally. So this was one of the minimal invasive, since he did not develop any seizures post-operatively and he was pretty much settled. So we went ahead and did a second cryoablation for intracranial portion, and this was the post-operative. What we see, there is good zone of ablation which was there. Was slight increase in the size of the tumor, but it was well controlled. Patient was asymptomatic. So we went ahead and did a second cryoablation, and second cryoablation we actually went ahead in the neural foramen, and then we went from the intraaxial portion to in the intraaxial portion, and this is what the approach was taken. It was far oblique portion, and this is a reformatted image is what I have shown, and we actually went into the intraaxial portion, and this is how we did a cryoablation. We were knowing that we can't do A0 ablation, but our aim here was to debulk the tumor rather than to do a complete ablation. Basically to shrink the size of the tumor, and patient would become asymptomatic, because these are benign tumors which can be managed in a conservative manner. So, so this was the post-operatively what he developed, since it was very much close to the foramen. So there was some edema which developed, patient developed hydrocephalus in the post-operative period. And what we did, we so he was initially okay just after the procedure. GC was 15 by 15, but it dropped significantly as the hydrocephalus and the pressure increases, and in post-operative period we did actually VP shunt, and then patient was okay. We are awaiting for the follow-up to see how well it has responded, whether it has actually shrunk over a period of time. So we are waiting for that follow-up. So this was when I went through literature, there were a couple of case reports and case series. What we come across, there was cryoablation in the brain metastasis which was there, and they actually had done 6 patients for cryoablation in brain metastasis, and this was intraoperatively, obviously. So this was intraoperative. So we can think out of the box and see that these are some of the difficult cases for surgery, for radiotherapy, re-radiation, and we as a IR can come and do some of these interesting and challenging cases. So this was again one of the another literature where it showed that cryoablation for perineural tumors in intracranial portion of trigeminal. So this is one of the case. Second case was, so patient was already operated for medullary carcinoma of thyroid. Patient had already undergone total thyroidectomy. There was neck node which was there, and this was a neck node which was seen, and this was very close to the trachea, almost stuck to trachea. So here any form of ablation like RFA or microwave, the hydrodissection would be a pretty much challenge in this case. Why? Because it is post-operative, it is already radiated. So hydrodissection does not work well as we see it in other places when there is no surgery or no radiation given to the patient. So this was the node which was there, which was closely abutting the trachea. And then what we did biopsy just to prove whether it's met. So we went ahead with posterior approach. And after that, what we did was we thought that since it is very close to trachea, we do not want any injury. It is very close to the subclavian vessels as well, and there would be multiple brachial plexuses which would be coming along the way. So we went ahead and did IRE. So in IRE, what we went ahead and with the 4 probes placed all along the sides, and then we did a IRE, irreversible electroporation here. So this was how the electrodes were placed. So they were placed via the cannula, and through cannula we introduced the IRE electrodes into the lymph node which was there, and what you can see here, it is closely abutting the trachea. So this was what the zone of ablation was formed after the during the procedure, and this was a pre-ablation and this was post-ablation. There was complete ablation without any residual, and this is a follow-up at 6 months of what we see. So there are multiple literatures. When I went ahead and did some literature search for irreversible electroporation in lymph nodes which are post-operative, and these are in metastatic setting. So most of the patients in head and neck tumors would already have received some form of surgery, or they would have already done neck dissection, and then it would be difficult for us to do some amount of hydrodissection. So this is again literature. People can go through this literature, and this is basically safety and efficacy for irreversible electroporation in metastatic lymph node setting. Coming on to third case, just a minute.
Last 2 minutes.
So this was a 20-year-old female who had a glomus tumor in the tip of the index finger. Patient was already operated once. She had symptoms of pain, cold, pressure, sensitivity since 6 months. So she also had some restricted range of movement during flexion and extension due to severe pain, and on the visual pain analog score it was 7 on 10, whereas on movement it was increased to 9 on 10, and it was affecting her day-to-day activities. So first what we did, so since it is a glomus tumor enhancing, maybe it would behave similar to some of the hemangiomas which is there. So we went ahead in the MDT discussed about the sclerotherapy, but sclerotherapy did not show any response and patient had unchanged pain score. So so the second possibility was patient was denying any amount of surgery because she was actually afraid about the surgery. On the day of the procedure, we started with RFA, so that's pretty much safer because we want a smaller zone of ablation. We did good amount of hydrodissection, but somehow due to there was impedance error which was coming up every now and then. So we went ahead and did microwave ablation for this. did good amount of hydrodissection surrounding it, and this is post-operatively. What we see, there is no enhancement seen post-operatively which was seen pre-operatively. We can see here good, and here there is no enhancement which is seen, and this is what we had published in JVIR. This was a case report which we did publication in JVIR and which was accepted here. So these are some of out-of-box cases which I think we need as a IR to be focusing on. And these are some of the challenges as well, and maybe we can do along with the teamwork with the multidisciplinary approach. And I thank everyone from my department, Dr. Shuya sir, Dr. Nitin sir, and our whole IR team and my disease management group.
So that was really a great talk. Now we move on to the next talk, challenging the lung ablation by Dr. Roy.
Yeah, good morning. Does thermal ablation really work in the lung? The answer to that is in that image that you see there. This was the first thermal ablation case done in India back in 2002, which I did. And you can see the excellent response over the first year. Well, the short-term benefits of thermal ablation has been found to be superior to SBRT and surgery. It has been published extensively that for stage 1 disease, the benefits are better. But so it directly makes this a treatment of choice for patients with early lung cancers who have poor life expectancy, either due to advanced age or comorbidity. And it's an excellent treatment option for patients who don't consent for surgery and also those who present with oligometastatic pulmonary disease. Well, in my practice, my main challenge had been to ablate the tumor with a substantial volume of tissue around it to be sure that I'm not leaving behind a tumor cells in the margins. Now, the recommendation for this is to burn the whole tumor with 4 times the volume of tissue around it. That is for a 1 centimeter diameter tumor. You're supposed to burn around a diameter of 4 centimeters. Well, that is why this is a big challenge, and it is easily said than done. And that is why smaller tumors respond better to thermal ablation. What prevents this is the tissue adjacent to blood vessels which are larger than 3 millimeters in size cannot be adequately heated because the flowing blood carries away this heat. And this is predominantly seen in radiofrequency ablation because the dispensation of heat is very much slower as compared to microwave. Coming to targeting challenges, it is considered highly beneficial to strike your target in the first pass because multiple passes increases and multiplies your injury, your complications significantly, which might be a problem for you and for the patient. So it is clear that targeting smaller tumors and tumors that are constantly moving is quite difficult. And also large tumors pose difficulties because you have to place needles in strategic locations within the tumor for a complete ablation. And there are few rules that you have to follow. So avoid sticking in the needle through emphysematous lung and also avoid sticking in the needle through fissures because passing the needle through fissures is like piercing the visceral pleura thrice. Well, to achieve this, to negate the movement of tumors, what I do is I fall back on general anesthesia and ask the anesthetist to hold the breath, hold the bag in a phase of inspiration so that the targets don't move. And to avoid the fissures and emphysematous structures, falling back on the help of a navigation device which allows both craniocaudal and orbital angulation will be helpful. Well, pneumothorax is an inevitable complication. It occurs in some studies up to 50% of cases, and 15% of them will need intercostal drainage tube. And the risk factors for this has been emphysematous changes, multiple needle passes, and traversing fissures. As I told you, you can reduce the chances of pneumothorax by refraining from passing through the fissure. There is a RF ablation needle passing through the oblique fissure. You can see pneumothorax immediately occurring. So you have to be smart and pass the needle parallel to the fissures and not across it. And hemorrhage is another problem, can cause problems because it obscures the tumor and you will not know the exact the volume that you are ablating. The tumors, bleeding is more common in the center of the lung where the vessels are bigger, and when you're using larger devices like microwave, which is the caliber is larger, so the chances of trauma is more. And in the periphery, the bleeding can cause hemothorax, and in the center, it can cause hemoptysis. And hemoptysis is, can cause movement of patients when he coughs and create problems. And also, while doing it under general anesthesia, a bagging anesthetist can push the blood back into the lung, and this can cause fall in oxygen saturation. And a very morbid complication is bronchopleural fistula, though rare. It can happen when you injure the major airway. And bronchopleural fistula can also occur during in a tumor which is healing can cavitate, and this cavity can break into the fissure or the pleura and cause bronchopleural fistula. The bronchopleural fistula patients might need an intercostal drainage tube for a very long time, or they might also need surgery for correction. An almost fatal complication that we come across, which is, but it's very, very rare. Every time I even do a biopsy, I thank God that has not happened, is an air embolism. So when your needle can create a track between a pulmonary vein and the airway, and the air can get sucked into the vein and find its way into the left heart and then into the systemic circulation, and it's almost always fatal. And when you suspect this, it is always, you will have to put the patient in Trendelenburg and increase the flow of oxygen. Other complications are rib fractures when you do in the ablation, the periphery of the lung. And this is one area I like RFA better than microwave, is because when you open the tines within the tumor, you can actually push it away from the pleura and avoid injury to the chest wall. And when you injure blood vessels, you can cause pseudoaneurysms. And nerves, I'm told, cryo is more, the nerves are more forgiving to cryo than to thermal heat. And when you do the procedure in a patient who's got a pacemaker in place, always keep electrophysiologist in the loop. He might have to switch off the pacemaker and switch it on after your procedure, or sometimes you might...
Last 2 minutes.
And but a nice call for 2 minutes. That reminds me of IPL. Okay. Make sure that you keep your device, your electrode away from the RFA, the pacemaker electrode or the pacemaker device. And if your grounding pads are not making good contact with the patient's body, the thigh, you can cause thermal ablations there. So you have to be very careful that you stick your thermal pads correctly. And also, as I told you, when you do the RF procedure or a microwave procedure in the periphery, you can cause burns in the chest wall. So always, before going for embarking on these procedures, know your complications so that you can avoid them. And if you come across the complications, you should know how to manage them. So thank you and God bless.
Saying no to ablation, a quality and safety perspective by Dr. Rajesh.
Good morning, everybody. Thank you, ISVAR, for this opportunity. I think my talk, after looking at everybody's challenging and extreme cases, is targeted at young IRs who are just beginning their practice and fellows who are starting to practice and a few ablations into their practice. So, how to improve your ablations? Always discuss a case at MDT. Do not decide. An MDT should consist of a medical oncologist, surgical oncologist, and radiation therapist. Remember, you are part of a team. You don't have to take all the decisions by yourself. Your knowledge is limited. So, and also when you're a team, always liberally use the help of anesthetist while planning for procedures. There's an increasing trend to do everything by ourselves. I'm going to finish the procedure, I'm going to be the anesthetist. So use, the patients come to you for a painless procedure and intending at cure. So remember that you're part of a team. If you don't have an MDT in your hospital and you want to do oncologic cases, you can approach a nearby hospital which runs an MDT, run the cases in their MDT and ask for opinions. There are online MDTs also available. You can participate in a neighboring hospital's online MDT. Be up to date with available literature. Not just literature in interventional radiology, but also what's new in surgical oncology and medical oncology. That helps you being planning the best treatment option for your patient. You don't want to be doing a procedure that was relevant 5 years ago today. Liver tumors and lung tumors can be ablated with multiple different techniques. So there may be a pressure or fear of missing out because there is cryoablation, there is IRE or new techniques. You don't have to jump in and do all the techniques. You do what is best in your hands, and if the literature supports that, for example, if microwave and cryo are not different, you don't have to use the latest technology. If there is a laser, you don't have to use that. Stick to what's good and what's supported by your literature. Use appropriate imaging technology before and after you ablate a tumor. If in doubt, always seek help. Ask your colleagues in the same hospital or call your colleagues from your association. There's no shame in asking for help and to get the best results for your patient. Before planning a procedure, don't just plan for success, also plan for failure. If there is a bleed, what do I do? Are those contingency mechanisms in place? If the patient has a pneumothorax, what do I do? Is the crash cart in place in the hospital? Where is it? So during your first 10 ablations, dry run the procedure. You don't start the procedure, just take one of your staff and run through all the potential scenarios that can go wrong. If there's a bleed, where's the cath lab? Is it available? Should I schedule it? If it's a high risk procedure, should I block the cath lab? Are the devices, pleural drainage catheters available? So plan everything in your mind and also enact these scenarios for the first 10 cases. So once that's done, everything will be in autopilot mode, and even if a complication happens, you will be able to handle it easily. It's always easy to get carried by your last most successful case and forget your most disastrous case. Audit your cases, check your results frequently, at least once in a year. Audit a case and see how many morbidities, how many mortalities have happened. Otherwise, our memories are very short-lived. Audits are a very important point
to improve your practice. Use combined therapies if required. If the HCC, for example, is larger than 3 centimeters and if the patient is not a surgical candidate and not amenable for other therapies, combine with ablation and TACE. Don't be hesitant to say to the patient, don't stick to one modality. If, for example, I've seen patients where 8 centimeter liver tumors have been ablated using multiple needles. Don't do that. Do what's needed for the best outcome. After your ablation, perform accurate imaging follow-up. If you are not comfortable with contrast enhanced ultrasound after an ablation, if a CT or an MRI is required, do immediately after ablation so that you have a baseline to follow up. Never shy, because if you don't do a good imaging after ablation, you might not be able to see if it's a recurrence or a residue. Acknowledge failures, acknowledge complications. If you have a complication, own up that this was caused by the procedure and you are responsible, and take ownership of that. That's the only way that the patients and your colleagues are going to respect you. I think these are my 10 points drawn from one of the articles, but very helpful for all beginners. Thank you.
So that was really a great talk. So do we have any questions? So now we move on to the second session on Euro-IR.
அனைவருக்கும் அன்பான காலை வணக்கம். Good morning, ladies and gentlemen. How are you doing today? Yes, as mentioned, it's going to be about solitary renal mass management, and I invite the chairpersons for this session, Dr. S. Maniharan and Dr. Atan Kumar. May I please request you to join us on the dais? Ladies and gentlemen, bring the energy into the room, applaud and welcome our speakers onto the dais. Nice big round of applause. I know you had lots of fun. Show all the energy. Yes.
Yeah, good morning. So we're already running short of time, so without wasting, we'll invite the first speaker as Dr. Ujjwal Gorsi, Professor of Radiology at PGI Chandigarh, to start with. I think you're covering your initial talk also 3 ablation cases combined with this continuous talk. Please, Ujjwal Gorsi on the stage, please.
Very good morning to everyone. So basically I had 2 talks. I have combined them just to show how do I perform a usual renal ablation and what are the difficulties which I have faced and how we can try to address them. So indications, as we all know, it is curative for smaller lesion less than 3 centimeter. Usually used in a patients who are surgically unfit or where preserving renal function is paramount, like CKD, solitary kidney, or VHL-like conditions, or patients who are poor surgical candidates and recurrence after surgery, and also in palliation in larger size tumor. So the first thing is pre-procedure, what you should know. The first thing you should know is that you have to have very good imaging, ideally less than 1 month old. Then you can either do a contrast CT or non-contrast CT just before the procedure. And mostly people in Western, they do ablation under general anesthesia, but we do it under local anesthesia and sedation and use both ultrasound and CT guidance rather than using only CT guidance, which people in Western countries do. And biopsy of renal mass is a must if you are doing for any renal ablation. So why imaging is important? So first thing is this. So this patient had a small hypoechoic lesion, interpolar region. So CT was done, someone labeled it as clear cell RCC, but when we were reviewing the imaging, so we thought it doesn't look like a clear cell RCC, so let's do something else. So, so we performed, with that, this will run, okay. So we performed a contrast enhanced ultrasound because I was not sure whether this is a true lesion or a pseudo tumor. So this actually is a pseudo tumor. So before going for ablation, know that everything which looks like a tumor may not be a tumor. Another patient, so this patient had a CKD, so contrast could not be given. So it was reported as multiple lesions, and multiple lesions patient cannot undergo surgery, so referred for ablation. So NCCT was done. They also, again, it was labeled that there are 2 lesions within the right kidney, but then when we did MRI, so the T2 lesions are hyper intense, okay, but when you see diffusion, there is no diffusion restriction. So T2 hyperintense lesion with no diffusion restriction, it's again a pseudotumor. So you are not going to ablate them. You should know that this is a pseudotumor. So for any good intervention radiologist, most important slide is this. Don't pay blind attention to WhatsApp discussions that diagnostic radiology is not important, you have to be only IR. All good IRs are very good diagnostic radiologists that can change the way you approach a case. So renal mass biopsy is a must before thermal ablation, or so there are 2 schools of thoughts that you do it in the same setting. You do ablation and in the same setting, you biopsy and ablation in the same setting, or you do biopsy first and then let the report come, because 30% of these lesions will turn out to be benign. And then you do ablation at a later stage. So we tend to follow the first rule. So this is actually a renal nephrometry score. It is for partial nephrectomy, but we can actually extrapolate this to renal ablation also. So radius less than 4 centimeter, 4 to 7 and 7, and exophytic, endophytic, nearness to the tumor. So these 3-4 parameters are there. So it's not that if there is a score of more than 10, it becomes contraindication. It just tells you that your procedure is going to be a difficult one, and you are going to need some more ancillary technique to actually approach this. So this algorithm actually I found very useful when I was starting my practice some 6-7 years old before. So ablate algorithm for all renal masses, C for this A, B, L, A, T, E. I'll explain it in a next slide. So axial tumor diameter, so if less than 3 centimeter, your results are going to be very good. If it is more than 3 centimeter, try to use cryoablation rather than RFA. Bowel proximity, if the tumor is less than 1 centimeter from the colon or small bowel, you will need some kind of displacement, either hydrodissection or maybe just shifting the position. Then location within the kidney, so if it is anterior and anterolateral, you probably need to go through liver. If it's anteromedially, then you will need hydrodissection. Posterior and lateral are the easiest one for partial nephrectomy, also for ablation. So if the lesion is adjacent to ureter, ureteric injury you have to avoid. So in that case, you need pyeloperfusion. And if it is touching the renal sinus fat, then earlier it used to be said that it's a contraindication, but with cryoablation it has been shown that even if it is touching the renal sinus, you can absolutely perform ablation without any issues. And endophytic and exophytic lesions are easily seen. Endophytic lesions are difficult to see. So you will either do ultrasound, you may do contrast enhanced ultrasound, or what you do is you do a contrast scan, and when you reaches the delayed scan, then on delayed scan see the relationship of a particular calyx with the lesion. So that makes the visibility little easier. So, theory part is done. So next time I'll be running through the cases, how we do typical case and what to do if case is not typical. So this is a typical case, posterolateral lesion. So, so it's a clear cell RCC, it is hypervascular, it shows washout. So you put on ultrasound guidance, you see the lesion is around 3.4 centimeter. Lesion was on a bit larger diameter, so we chose cryoablation. So we still did it with RFA, earlier lesion. So this is the RFA, multi-tine RFA. You can use single-tine, multi-tine. So, and you just ablate it, and after ablation you can see that there is no enhancement. Another lesion, so it looks easy, simple posterior lesion, but when the patient was taken for the procedure, so actually now lung has started coming. So in that case, what you can do is you have to enter inferiorly and then angulate your needle superiorly and then do this ablation. So like this case, so now you are again, I mean, rather than doing exotic things, just do it under ultrasound guidance, start from inferiorly, move upside. Another lesion, so it seems good on spine, but when prone was done, so now this red arrow is small bowel, so bowel has started coming, so you cannot ablate it. just like that. So what you do, cryoablation was done in this patient. You place the probe, you stick the probe, and then you do hydrodissection. So hydrodissection, RFA, you have to use dextrose, whereas in cryoablation you can also use just saline and you can do your ablation. So so this is another case in which a patient, he is an elderly gentleman, he has RCC on both sides. So on left side, it's a easy lesion. So you just go there, do RFA, and you do your ablation. So here I would like to give attention that many times renal lesions which look exactly circular, they are not circular. They have a tongue-like extension which goes towards the sinus. So unless you can control this medial tongue-like projection, patient will definitely lead up with either residual or recurrent disease. So this lesion appears circular, but if you see carefully, there is this tongue-like extension of the tumor which is reaching till the renal sinus. So if you are not going to control it, you are not going to achieve the margin. So it was again, cryoablation was seen. So you can just see the position of my needle, how deep it is there within the renal parenchyma, just to ablate this tumor. So these are just some VRT images to show, and these are the post-procedure images where we can see that both lesions have been taken care of. So another lesion, it's very hard to see this lesion. The lesion is completely endophytic, hypodense. So I think I'll sleep for 5-6 minutes more because 2 talks are combined into one. So this is the lesion here. So we targeted it under ultrasound guidance, endophytic, and then here is the complete hypodense rim you can see after the cryoablation. So again, 45-year-old male, left nephrectomy already done. So again, he has a lesion. So you see the location of the lesion. It's a central hilar lesion, one of the most difficult lesion to actually ablate. So you can see here, the lesion is there and it is reaching till the renal sinus. So again, you do under ultrasound guidance, you put a probe. So the thing is, if the lesion is reaching till the renal sinus, if it is a large lesion, you should avoid using RFA and microwave. Always use cryoablation. Cryoablation is safer. So under CT guidance, you place probe, and then this is the ice ball you can see. So that is the biggest advantage of cryoablation. You can see the ablation zone, you can see the ice ball. So you know exactly where your ablation zone is, and you don't over ablate it, and you don't cause sinus injury. So this is post-procedure, no residual tumor. So just as I was telling, there are enough studies which shows that even if your ice ball, if it reaches the renal sinus, it's completely safe, nothing happens to the urothelial, and there is a scientific reason for that, because histologically it has been seen that cryoablation causes slowing of urothelium, but it preserves the smooth muscle layer, so injury is not that severe, you can get away with it. So for lesion which are close to the ureter, always do pyloperfusion, so just to avoid ureteric injury. If large lesions are there, like 4 or 5 centimeter, you can do a pre-op embolization just to reduce the vascularity, reduce the size, reduce the bleeding complication, and then you can ablate it. So sometimes the lesions are very large. So like this was the patient, routine screening done for cirrhotic patient. You can see ascites, there is cirrhosis. It was done for HCC, but patient did not have HCC, but he had a large RCC. So the tumor is approximately 5 centimeter. It's an endophytic, exophytic tumor. So here again, cryoablation works very well. So you can place multiple probes simultaneously, like what was done in this case. And after placing these multiple probes, then you have to play with the configuration, but you actually need to ablate it, and then you can see that there is no tumor recurrence is there. So another lesion, the solid cystic lesion, interpolar region. So you ablate it, and this is post-ablation. You are happy about it, but then after 1 month, you see there is a small residual lesion in the anteromedial part, so anterosuperior medial part. So now you are stuck what to do. So instead of doing very flashy things, what you can do is just take a 22G needle, put alcohol and target the lesion, and you can see this black thing is alcohol, so you can actually ablate the tumor just with a 22G needle if the residual tumor is still there. Sometimes this is the lesion, anterolateral lesion, so you can see that this is a superior anterior lateral lesion, so there is no way you are going to approach this lesion. Axial coronal sagittal. So in these cases you can actually do a transhepatic ablation. So you do under CT guidance, go through segment 6, and then you can ablate this tumor, and this is the post-op image, this is the post-ablation image. Again, enough studies, if nothing else is there, you can do a transhepatic RCC ablation. So another patient, I think this would be the last. So this is an anteromedial tumor. So there is it's very difficult to approach. You can see that there is a bowel which is coming anteriorly. There is also a branch of superior mesenteric artery. So in this, you can actually go transperitoneal. So if nothing else is there, so you can grow transperitoneal. You discuss with the patient. Patient has only one kidney. Other kidney is not there. If they go for surgery, they may land up in nephrectomy. So in that, transperitoneal approach can be used, but you have to be careful with your approach. You do hydrodissection, make a plane, and then you go ahead and ablate it. So just these are all difficult maneuvers you can do to do a good, safe renal ablations. So my take-home message, as I already told, being a good diagnostic radiologist, renal biopsy have to be performed. Larger lesions, central lesion, do cryoablation. And if you are early in your career, then follow ablate algorithm, which I mentioned you earlier. Thank you a lot.
Thank you for your excellent presentation. If there any question, we can take up. Yes.
My name is Mohan, I'm from Singapore. So we have a separate Department of Interventional Radiology. We don't do any diagnostic work, we do only interventional work. So if you have to become a good interventional radiologist, something has to go. You cannot be good at everything. So
it's not that you do everything in diagnostic radiology, but the tumor which you are going to ablate, organ which you are going to ablate, you should know the differential diagnosis of the masses.
I'm coming to that. So,
only that.
I'm coming to that. So what you have to do is you have to pick a specialty. If you are a uroradiologist and you do uro intervention, you cannot be a radiologist and an interventional radiologist in every specialty.
Yeah.
So that's what we should drive. Yeah, that's what we should drive. Thanks.
Just to add to Ujjwal's credit, just like me, Ujjwal's also kind of predominantly he's moving towards exclusive Euro IR, I think. Yeah.
Thank you. So we will call upon next speaker, Dr. Madhu ST. He is going to present on SRM in solitary kidney and VHL.
Good morning, everybody. So Dr. Ujjwal made my talk actually a lot easier. So I'm going to talk on the solitary renal masses in solitary kidney and in VHL. So what is the small renal masses means? They are nothing but tumors which are of less than 4 centimeter in size. As we know, the RCC is the 14th most prevalent malignancy, and the small renal masses in a single kidney definitely pose a problem. So their incidence of late has increased. That is because we are regularly doing imaging, abdominal imaging for some other purpose. So the pickup rate of these masses has drastically increased over a period of time. Traditionally, they were treated with radical nephrectomy previously. Over the past 2 decades, the treatment plan has changed from radical to partial nephrectomy. And nowadays, from the last 1 decade, active surveillance is has taken up, is becoming the first mode of treatment for this, first mode of management, and ablative therapy is also moving forward. So, what are all the strategies for small renal masses in a solitary kidney or in a patient of a VHL? So, as per the guidelines, as per the NCCN guidelines, as per the European and American Urology Society guidelines, active surveillance, ablative therapy, and partial nephrectomy. These are the 3 modes of treatments or management available for solitary, small renal masses in a solitary kidney. Why active surveillance? This is because these small renal masses usually are low grade, They are slowly progressing tumors with a limited metastatic potential. This is the basis for putting active surveillance as first mode of management in these tumors. Surgery-related morbidity and renal dysfunctions are quite common with post nephrectomies in a solitary kidney. Suppose there is a single kidney and you are going again for a partial nephrectomy, so patient will land up with renal dysfunction. Ablative therapies have become an alternative in such a scenario. Where these active surveillance and ablative therapy are preferred, they are preferred in elderly patient with multiple comorbidities and pre-existing renal tumors, even with a bilateral kidney, and of course solitary kidney and hereditary or multiple tumors. In these scenarios, we prefer more of ablative therapy and active surveillance. Coming to active surveillance, what exactly we do here? So we are going to monitor the tumor size by serial imaging, most of the time by CT scan, or if the renal dysfunction is there with MRI, and we delay the intervention for tumors which are progressing. Till the time of progression, we are going to manage this case without any active interventions. So usually the patient selected for this is frail and comorbid patients. And as per the American Neurology guidelines, the lesion of less than 2 centimeter should be selected. And when to do the imaging? First year it should be repeated every 3 to 6 months, thereafter 6 to 12 months. When the active intervention should be done? If the tumor size increases more than 3 centimeter, there is a stage progression, there is a growth kinetics more than 5 mm increase per year, and the clinical changes in patient and tumor factors, and additional biopsy results show that the tumor is like either a clear cell or there is a dedifferentiation into clear cell. In such a scenario, we should go for active intervention. The sole reason why we are going with active surveillance is many of these exhibit indolence or a benign behavior. So is it really effective, the active surveillance? Yes, as per the Perozium et al., this active surveillance is not inferior to primary intervention in terms of cancer specific survival over a period of 5 years. Not only that, the Metcalf et al. Also showed that even in a younger patient, less than 60 years, if the active surveillance is the mode of treatment, the overall cancer-free survival at 5 years is not inferior to the active management. So it has its role. Finally, what is the consensus with respect to the active surveillance versus the active intervention? Active surveillance is a reasonable strategy for an elderly patient with comorbidities. Active intervention, particularly partial nephrectomy or ablation, is more suitable for younger individuals. So, I will come to the ablative technique. What are the types of ablative technique? I think Dr. Ujjwal clearly mentioned what are the ablative techniques available. I don't want to spend much more time here. So since 2017, the American Neurology Association has given clear guidelines saying that ablative techniques as a valid alternative to the surgery, to the partial nephrectomy in cases with a T1A stage, less than 4 centimeter. The outcomes are comparable to those of a surgical resection with a 5-year cancer-free survival of say 95%, and a risk of local recurrence and metastasis tend to be more prevalent after ablative therapy compared to the surgical approaches. However, we don't have any randomized clinical trials. What are the observations is only on observational studies. So this was discussed in previous talk also. The cryoablation is its own advantages. Lesion more than 3 centimeter or very close to the pelvic ileus system, the cryoablation has an advantage. So real-time visualization of the ablation is the another advantage with the cryoablation and less painful compared to RF. So what is the disadvantage with the cryoablation? It's a longer procedure time, more risk of bleeding, as in any thermal ablative thing, the blood vessels may go for cautery kind of, but in cryo that doesn't happen. With RF, it is widely available. I think nowadays everybody moving away from RF to microwave. So shorter procedure time, less bleeding risk, but however, the lesions more than 3 centimeter and the lesions which are very close to the PCS cannot be ablated. So microwave lesions more than 3 centimeters can be ablated. Heat sink effect is less compared to RF. and the procedure is more painful. You need to do it under sedation or under GA. And IRE, of course, it avoids the challenge, changes in temperature, so no heat sink effect, so risk of vessel damage. That's the biggest advantage. And the IRE is not, like we don't have much clinical experience with IRE. So in radio frequency ablation, how the heat is generated, ionic agitation will create the heat by the delivery of current through the probes. So the elevating the temperature up to 60 degrees. Usually we start with 30 to 40 degrees with incremental increase of 10 watts every minute, and it provides excellent local control for T1A tumors. So the 5-year overall survival, cancer specific survival is up to 95%. So the limitation is heat sink effect. It's less effective if the tumor size is more than 3 centimeters, centrally located masses, and the one which are close to the ureter and POJ. So cryo, as discussed, for more than 3 centimeter and real-time imaging monitoring is the advantage with cryoablation. And microwave, here it utilizes electromagnetic waves to generate the heat, and it induces cell death through hyperthermic injury. So IRE,
last 2 minutes.
In IRE, the electrical field generated induces changes in electrical potential across the cell membrane and destabilizes the lipid layer. That's the mechanism. I'll just go to the follow-up thing, how we follow up, and what is our strategy for on timing for the follow-up. Most important point to evaluate after the ablation is completeness of the lesion ablation to achieve an effective therapeutic response. CT or the MRI is which is used to assess the follow-up. The tumor enhancement characteristics and size measurements on follow-up are very, very important. Focal or curvilinear enhancement most of the time indicates a tumor progress or tumor recurrence or a residual tumor. So distinguishing local recurrence from post-ablation post-ablation inflammation is very, very critical. So if there is a recurrence in the tumor, again there is small recurrence, there are small residual lesion, you can always go with the active surveillance. These tumors less than 4 centimeter tumors, they're less aggressive. Even if there is a small residual lesion, you can always go for a active surveillance. So I'll just go to a few cases. So this is here's a 24-year-old male with VHL with left nephrectomy, and there was a small RCC in the right kidney in lower pole. It's quite easy location to ablate, no vital structures around. So post ablation, there was no residual lesion, very small lesion, very easy to ablate, and there was no residual lesion. He is continuously on follow-up since then. So case 2, 40-year-old male, right nephrectomy for multicentric large RCC, now with a left RCC. He is having one large lesion in the mid-pole region, and another lesion in the lower pole posterior aspect. So with respect to the location, there is no difficulty here. So but close to the pelvic system, another 2 minutes. Close to the pelvic system, but we can get away with it. So the post ablation, these are the images. So we did contrast once. Afterwards, we didn't do contrast because of single kidney, and his renal dysfunction was there. He was maintaining around 2 creatinine. So we didn't do contrast afterwards, but we were following with the MRI images. There was no local recurrence in this case. So we'll go to the next case. So this is quite a difficult case. This is one case like there was a HCC in the right side and RCC on the left kidney. So surgeons operated the HCC, but they didn't operate on the RCC part. They told like we'll operate later, but the patient was not willing for surgery. So we did ablation for this, and post ablation this is how it is looking like, and there is no residual lesion, and he's on follow up for the same. This one case is a 50-year-old male with a CLD with a portal hypertension. He was diagnosed with RCC 1 year back. So unfortunately, his platelets and INR were deranged from the beginning. Platelet maintaining around 20 to 50,000 and INR oscillating around 2. So we kept him on active surveillance for 1 year, but there was a progressive increase in size. So the patient didn't himself wanted a surgery, but patient's relatives they wanted. So this is the cirrhosis, and this is the lesion, and it was increasing progressively. We did microablation just last week with doing some hydrodissection due to the bowel which is closed, but unfortunately he landed up with hematoma around the thing. So this is purely because the platelets, we increased the platelet, like we gave one SDP, multiple RDPs and FAPs, but the platelet increased only up to 70,000, and the INR was around 1.4 to 1.5. We anticipated this. We even suggested to go for a pre-op embolization followed by ablation, but patient was not keen. Any one procedure he wanted, but fortunately nothing much happened. The HB dropped from 11 to almost 7 to 8. With the transfusion is managing, and we didn't do any active intervention after that. So another case,
so
the
Dr.
location
Madhu,
is just one more minute. So location is like anterior, very close to the bowel. So for this, the hydrodissection is very important. The approach was lateral, and we could clearly do the ablation for this, and there was no complication anticipated. Thank you.
Thank you so much for this great presentation. So I think we'll just move on to the last session, which is the debate. And for that, we have 3 speakers. I think we'll call all of them panelists together on the stage for this active debate.
Absolutely. Doctor, just a request. I just want to tell all the speakers here that many of our speakers have flights to catch. So that's the reason why we're very strict on the timing. So please, of all days today, please follow time. And many of you have kept your mobile phones on, so please put it on silent. It's a request. Over to you, Doctor. We have a urologist with us, Dr. N. Raghavan, and radiotherapist, Dr. Mahadev.
Yeah, please. So we will call both of them on the stage along with Dr. Rohit Khandelwal, the interventional radiologist. Actually, all 3 of you can join together. And I'm sure it will be a short, quick, but a very crisp and a very effective debate on surgery versus radiotherapy versus interventional radiologist. So I'll give the stage, maybe 2 of you will just shift it, can join.
It's okay.
Yeah. And
chairman should be in the middle all the time.
Yeah, please.
Over to you. Yeah. I think we are supposed to do a quick presentation is what I was made to told.
So maybe one by one you can
Yeah, we can start. The intervention radiology can go. Sure.
Good morning, everyone. I am Dr. Rohit Khandelwal. I am going to present ablation in the RCC. So these are the guidelines already discussed in previous lecture. So there are a couple of things are common in guidelines. First, these guidelines favor partial nephrectomy as preferred method for small renal massage and ablation as alternative treatment. Second thing, there is a no intervention radiologist of panel of these guidelines. So these guidelines have inherent bias. Third, these guidelines are based on old data. Now there are better recent data is coming towards favoring the partial ablation, percutaneous ablations. So for renal mass evaluation, so we see 3 factors, trifecta: how much renal function is behave in future, is it safe, and oncology outcome in terms of overall survival, metastatic free survival, and recurrence free survival. This is the article, did trifecta analysis, and interestingly all tumors were endophytic. These are considered as worse for ablations because of high renal score. So ablation had significantly lower rate of overall complications, and decrease in GFR is more with partial nephrectomy. No difference in recurrence and recurrence free survival, and outcomes are comparable to partial nephrectomy. For renal function, there are a lot of studies and we have a strong evidence renal function preservation are better with the ablations. Most of the study favors thermal ablations. These are the images taken from Dr. Subra Chaudhary. These are long-term follow-up for 15 years and it works well. There is no local recurrence. So case was done 99 and follow-up in 2014. This is the 15-year follow-up. So long-term outcome of ablations. So 10-year overall survival are similar in partial nephrectomy and ablation arm, and top above, mean length of stay, ICU admission, blood transfusion and post-operative complications are significantly lower with ablations. I agree, reintervention rate is higher with the ablation compared to partial nephrectomy. For local recurrence-free survival was inferior for thermal ablation. However, we reach equivalence to other mortalities after multiple treatments. These are the old data. And across the all mortalities of ablation, either RF ablation, cryoablation or microablation, we are getting similar data of the cancer-free survival, overall survival. This is a differential between T1A and T1B. In this study, they compare thermal ablation, partial nephrectomy, and partial nephrectomy was associated with lower risk of lower recurrence. But in subgroup analysis, there is no difference in cancer-free survival in CT1A tumor, and there is no difference in distant metastasis or cancer mortality rate in both groups. Same in this finding that T1 and T1B, there is no significant difference in overall survival and cancer-specific survivals. Patients treated with thermal ablation had greater all-cause mortality because older and comorbid patients are included for ablations. Cost effectiveness, ablation is cheaper than nephrectomy. Now comes to SBRT. SBRT is less invasive, yes, but 20 to 30% of the small renal masses are benign masses, and recent guidelines recommended renal mass biopsy either or prior to ablations or any interventions. If we are going to do biopsy, we can do ablation at the same time with only marginal increase in complications compared to biopsy. SBRT requires 3 to 5 settings. Ablation is a OPD procedure or daycare procedure. There is a delayed assessment of imaging response on SBRT. There are limited data on SBRT versus nephrectomy or SBRT versus ablations. In this, there is a SBRT is inferior survival outcome compared to ablations and outcomes. For renal functions, in respiratory renal functions, the kidney which is going under SBRT for renal cell carcinoma, there is a 39% reduction in GFR in single fraction cohort and 62% reduction in GFR on 24 months follow-up in multiple fraction cohort. So who will survive? So there is no good randomized controlled trials. We need a good randomized controlled trial versus in these modalities. Ablation is providing great cosmetic benefit, less complications, but it is effective as well. So who is the ideal candidate for ablation? Is it elderly patients? Is it patient who has solitary kidney and CKD? Is it really? Ablation has suprarenal function preservations, minimal major complications, and long-term outcomes are comparable to partial nephrectomy in terms of oncology outcomes. So ablation should be offered to all patients, either he is a young, comorbid, elder, fit, can be offered as a preferred matter. To conclude, discuss ablation as a default option for eligible CT1A SRM patients and consider as an alternative option in T1B. We need more randomized and long-term data and support from our urologists. The question is not who should treat, but what's the best of patients. Sometimes ablation is not inferior to any treatments. Thank you.
Respected Chairman and a great audience, good morning on a Sunday at Chennai in our hometown. So this is standard of care, yeah? Restorol has to be compared with the standard of care, yeah? Keep that in mind. Secondly, who is eligible for NSS or nephron sparing surgery? Everyone is eligible. There is no anterior tumor, this tumor, that tumor, this tumor, no. Anybody can have it, yeah? Intrarenal, extrarenal, this renal, that renal, doesn't matter at all. How can I operate? I can operate on anyone. I can take it open surgery, laparoscopic surgery, robotic surgery, I take it or we leave it. Keep in mind, There are a lot of data, sir, quoted about complications. That was the laparoscopic era. Robotic era, where are the complications? That is a data published by people like Anant and me, not very far from now, and that shows that our complication rate is near zero. Gone are those days when partial nephrectomy had complications. Those eras gone. Of course, it still has complication if people with less experience operate. As much as people with less experience do ablation, they will have problems as well. So in good hands, it's the same. Any guideline, I agree with that. That guideline may have to include radiologists in future as well. I appreciate that. That is a good point to take. But the fact is, partial nephrectomy is doable in anatomically doable things. Not T1A, T1B, complex anatomy, doesn't matter at all. Partial can be done. However, I do send patients for ablations. It's not that I don't send patients. My super friends are sitting here in this audience. We have sent for bilateral tumors, where one big tumor we operate and the 3 centimeter tumor gets an ablate. And we do for VHL patient, where we have operated on one ablated and a few more. We do for recurrent tumors, and in partial nephrectomy, recurrent tumors are almost, I have not seen one. And definitely we have a cutoff limit of less than 4, and we have very, very good discussion before we start, sending these patients across. Do I believe in ablation? Of course I do. But do I believe that ablation is the panacea for all? No, sadly. Thank you.
So I think all of us agree that surgery is the gold standard. But then also there are other treatment options, and I think the patient should be aware of these options, and when necessary, these options should be offered to the patients. So stereotactic body radiotherapy has been there for quite some time, and it basically involves giving a very high dose of radiation in a very small period of time. And for tumors less than 4 centimeters, you use only a single dose of radiation, and only for tumors more than 4 centimeters, you may require more than one session, typically around 3 sessions or 5 sessions, depending on the size of the tumor. You can treat up to 10 centimeters tumor size without any major morbidity. Now, in absence of any randomized trials, and I doubt whether any randomized trial will ever be held between surgery and other ablative procedures, I think the best evidence is on meta-analysis. And there is a meta-analysis of almost around 800 patients of the efficacy of SBRT in solitary renal cell cancers. It is non-invasive, there is no anesthesia required. You do not require very sophisticated treatment machines. You can do it on a simple linear accelerator, or you could do it in a very advanced machine like a CyberKnife or a proton therapy. But it can be done in a very simple linear accelerator as well. So nothing very, advanced equipment is required. There is also evidence that radiotherapy has immunomodulatory effects. So if you look at why the cases that we should not treat with SBRT is when the pre-treatment GFR is less than 30 ml per minute, or if we have already given chemotherapy, or radiation has been given to some structures very close to the kidney, like CA colon or something, then these are the places where we avoid doing a stereotactic body radiotherapy. Also size less than 10 centimeters, as we already mentioned. This is the dose that we give, 20 gray in single fraction for for tumors less than 4 centimeters in diameter. It is a very high dose of tumor, and classically renal cell carcinoma is considered to be radio-resistant, but with these doses of tumors, normally they respond very well.
Last 2 minutes.
So what happens is that the way we assess response in renal cell carcinoma is slightly different than, say, surgery. So we use the modified RECIST criteria, and it is not always the size of the tumor that we see, but it is basically the viability of the tumor. And after treatment, the maximum rate of response is seen in the first 3 months, but you actually have to evaluate only at the end of 8 to 10 months. And what we would see is the viability of the tumor or the enhancement of the tumor rather than the size of the tumor. The size of the tumor will reduce by about 1 centimeter every 8 to 10 months. The side effects are less, and most of them grade 3 side effects would be around 8 to 10%. And this would be flank pain and sometimes severe GI effects, but otherwise no major side effects we see with this. Somehow, I think this is not my presentation, this is some other presentation. Okay, I think that's it. But there's some confusion. I think there is mix-up of some of the slides. But basically, stereotactic body radiotherapy is an alternative option compared to surgery, and can be done in a single fraction, non-invasive option without anesthesia. Thank you.
So that was a quite effective presentations from all 3 speakers, and I think maybe, sir, I'll ask you to have a concluding point, but we all know that all cases actually need to be discussed in MDT. We know that ablation therapies and SR, stereoactive, radioactive, are an alternative to nephron sparing surgeries, which have been traditionally the gold standard, but yeah, we're arriving, and specifically in scenarios as been discussed extensively, especially solitary kidneys, syndromic lesions, bilateral lesions, multiple lesions. Even ablative and therapies are considered a good alternative to a nephron sparing surgery. And for especially mid-polar regions, I think nephron sparing surgeries is a bit tougher ones, and definitely the ablative therapies do have an effective role. Any concluding remarks from the panelists?
The surgery always serves the purpose that the tumor is out. We know the pathology, whether it's a grade and what stage, what type of tumor, etc., etc., etc. And patients are far more satisfied with the surgery. Yes, complications and a surgical procedure is required. I'm not going to deny that. However, the complication rates in the current scenario of partial nephrectomy, especially done by reasonably experienced people, is near 0. So it's not that complication doesn't happen. It's an extremely rare thing to have, like any other technique. So now, instead of one offer of surgery, we have now 3 offers, as in they can have surgery or ablation or radiation, and it's up to the patient to choose what they want to do. The most important, in my opinion, I saw a couple of nice presentations, lots of pictures and lots of needle going here and there. It's all nice. What really matters is outcome. When we have data for 15 years published, and then only we can say what is our outcome. And outcome matters. It all matters how, it really doesn't matter how you do a technique or a surgery or an ablation. It really matters whether we are doing good to the patient, and what finally matters is outcome. That's all matters.
So obviously we have not any randomized controlled trial at present, good RCT, but we have long-term data for 10 years and 15 years, and partial ablation is working well. So Dr. Arjun is concluded well. So MDT should be done for all patients, for T1A and T1B, especially for T1A patients, and all options are discussed. The tumor with low renal nephrometry score 4, 5, 6 are ideal for both partial nephrectomy and ablation. High renal score, they are difficult for partial nephrectomy and ablation. Complication is higher. What can be done on both way? So options should be given.
Yeah, I think outcome matters, but you see, if you look at the results of all the 3 treatment modalities, you have at least 5-year data. And 5-year local control rates are more than 95% with either of these modalities. So I think, yes, surgery should be offered as a first option, but there are so many other cases where patients are not suitable for surgery, patients are not willing for surgery, solitary kidneys. When the local control rates are more than 95% and cause-specific survival rates, disease-free survival rates are as good as surgery, we have to think about it as an option, and patients should be made aware of these options that are there.
Thank you. Yeah, always good to have more than one option. Yeah. Thank you.
Thank you so very much.
Yeah,
Thank you, speakers. Please remain on the stage for a quick group picture. May I invite Dr. Ujjwal to join us on the dais? And thank you for being respectful of people's time. We really, really appreciate it. Thank you so very much. Join us for a quick group photo. Ladies and gentlemen, Dr. Madhu, can I please have you on the dais for a group picture, Dr. Madhu? Ladies and gentlemen, I have one more request to make. When the speakers are presenting, we request you to maintain silence. It so happens that when you give full attention to the stage, the speaker will end up sharing more knowledge. So for those reasons, please do not look into your mobile phones and give the speaker on stage your complete attention. Next up, our topic is going to be prostate PAE, and the chairperson would be Dr. Ram Kasturi. May I please invite you on the dais? Ladies and gentlemen, you know what to do. Give them a nice big round of applause and invite the chairperson for this session. The first talk will be given by Dr. Raghav Seth. PAE, where are we with evidence in comparison with various BPH treatments? Dr. Raghav, can I please have you on the dais? Ladies and gentlemen, nice big round of applause. Come on. Thank you.
Thanks very much. Thanks. Guys, it's very nice to see you all. Hope you're having a good time, especially the morning after the evening before. Take it away. He's going to speak about evidence for PAE.
Good morning, everyone. And starting the PAE session with the short discussion about the evidence, so that we can further discuss about the various nuances of this. So for any kind of management, for any kind of procedure, especially focusing on BPH or benign prostatic hyperplasia, the key drivers or what the patients want are, of course, symptom relief, safety profile, sexual function should not be compromised, and the speed of recovery. So these are the 4 important key drivers, and taking these into mind, the spectrum of treatment landscape that we have includes medical therapy. That is the first line therapy for BPH, we all know that. So alpha blockers, 5-alpha reductase inhibitors combination. Next, the minimally invasive surgical techniques. So aquablation, water vapor therapy, prostatic urethral lift, and of course PA is one of the minimally invasive treatment strategies for BPH. And of course the gold standard or the surgical standard we know, TURP. So just at a glance, if you look at the evidence, the 6 major randomized controlled trials have been performed as far as PA is considered, out of which 4 are versus TURP, 1 versus sham procedure, and 1 versus combined medical therapy. Multiple prospective studies, and now we do have 10 years follow-up data as well for PA with the 80% success rate, that is 20% recurrence rate at 5 years. And even if the recurrence is there, the recurrence is treatable. So discussing these outcomes just in summary. So PA versus TURP, this is one of the earlier RCT, 2014 and 2016 I have combined the results. So both improved the symptoms, but early results favor TURP, and over the time these differences narrow. Maximum flow rate again higher, better in TURP, and overall volume reduction will be in both, but higher in TURP because of course resection versus infarction, resection will have a higher volume reduction. This is another from BMJ 2018, so more recent as compared to previous 12-week outcomes only. no change from baseline if the IPSS score is no significant difference in both of them. Flow rate again better in TURP, TURPS. Safety profile, far significantly fewer complications in prosthetic artery embolization, especially related to the sexual function or ejaculatory function. 12-month outcomes, this is again more recent, JVIR 2020, and what they have concluded is mean decrease from baseline, if I talk about the IPSS score, is no significant difference between the two, same way for Qmax. Safety is far superior if you talk about PAE, and quality of life improvement again in both. So overall, great results so far. And just to prove that PAE is actually effective, sham procedure, that is again a sham controlled RCT that has been done, in which the prosthetic arteries are cannulated, but you embolize only in one treatment arm and not in the other. So there they have shown that PAE statistically significant superiority over the sham procedure for both symptom relief as well as quality of life. Another important trial that was in 2023, that is the PARTEM trial. This was PAE versus combined medical therapy. So both the IPSS and the erectile function score, both of these favor PAE strongly. So again, the similar type of conclusion. So just summarizing the system, till now we were discussing the RCTs. So systematic review and meta-analysis, 6 studies and used 598 patients by Knight et al. IPSS quality of life, again repeating the point, no significant difference, statistically significant difference is not there. Qmax and prostate volume definitely favoring TURP. Adverse events, hospital stay, so all these, that means comfort for the patients, more favored in PAE. Another very important concern is of durability and retreatment, which is usually asked by patients as well as referring physicians as well. So yes, the recurrence rate is 20% at 5 years, and we have follow-up up till 10 years. But even if repeat PAE is required, it is safe, effective, and even after PAE, surgery, that is TURP, remains an option, so it is feasible. As far as we have discussed about efficacy, safety is great. So lower total adverse events, major adverse events, hardly 2.5% without any sequelae, and no blood transfusion, 0% transfusion required, acceptable radiation doses. So good data as far as safety is concerned. And one of the stronger points of PAE, that is the sexual function outcomes. So all the ejaculatory rates and ejaculatory dysfunction rate are far lesser in PAE, and even the IIEF score as discussed previously. So overall, this one we as already discussed is far superior as compared to the gold standard as far as this adverse event is considered. So coming on to the consensus statements, this is statement 40 from AUA, American Urological Association 2023 update, and what they have mentioned is PAE may be offered for the treatment of LUTS, lower urinary tract symptoms, BPH, performed by clinicians who are trained in this IR procedure. Though the evidence level grade C, and they have given the recommendation as conditional, but still it is a positive point, because they are considering it within the standard urological care pathway, and also emphasizing the importance of procedural expertise. From our own societal guidelines, SIR, CIRSE, what they have mentioned and what they consider is that PAE should be considered for moderate to severe LUTS, patients who are poor surgical candidates, and with a preference to preserve ejaculation. I'll throw more light on this in this slide. So overall, if we see, it is a very busy slide, but the first part, that is the HOLEP or the laser enucleation, is kind of having a very, very good efficacy with high rates of deobstruction, but problem is in the safety or sexual side effects. The newer procedures, prosthetic urethral lift, water vapor thermal therapy, relief is moderate, but ejaculation is being preserved. Similarly for PVP, effective removal but bleeding risk. So the strategic sweet spot is in which we can have size independence, because this HOLEP laser, the first row, there is a learning curve and it cannot be performed beyond certain sizes. So if we combine the size independence criteria as well as sexual preservation in an outpatient setting, so PAE is quite near and offers an advantage in this strategic sweet spot. Of course, cone beam CT guidance and various other advancements in techniques, smaller microcatheters, micro guide wires available. So technical success rate is almost as good, as near to 100% as possible, with good predictability for prostate sizes more than 50 to 60 cc. So finally, just concluding what we can tell our patients, or how we should counsel them, or what is the basic summary of all these literature review, is that there is no doubt about that TURP is superior in terms of deobstruction, that is Qmax flow, as well as reduction in prostate volume. But when we talk about the symptom relief or the patient feels or the quality of life, similar as most of the studies are showing, but safety, efficacy wise and sexual function wise, PAE is far superior. So it has to be a shared decision making. If the priority is deobstruction, or we required a rapid minimal
Last 2
deobstruction.
minutes.
So rapid is the key word here. Surgery or enucleation will be a preferable option if the patient is accepting side effects, whereas if the patient wants to prioritize sexual function, whereas the gland is large or very large, high surgical risk on anticoagulants, then there's no doubt that PA is the treatment of choice for this cohort or group of patients. So just the clinical bottom line, summarizing my presentation, PAE is now considered as an evidence-based, guideline-supported option that is complementary to surgical therapies and ideally suited for patients who are prioritizing quality of life, sexual preservation, and minimally invasive recovery. So thank you. This is our team at Gangaram Hospital, and any questions will be welcome. Thank you.
Thanks very much. Very crisply done. Thank you. Guys, I suggest you write your questions down for the end. We can have a robust discussion. So let's move on now. So there's a small change in the working order here. So before we learn about challenges and tips and tricks, we're going to find out how to do it in the first place and how to follow patients up. So it's my pleasure to invite Alex from Virginia. Welcome, Alex. Let's hear how you do it. We're looking forward to it.
Thank you so much for having me. So yeah, my name's Alex Puidapa. I'm from prostate centers or IR centers. Just a little background, we have about 45 doctors who do PAEs or high-end embolizations with us. All those doctors come through different stages of their career, train with us to learn to do PAE safely and efficiently. And these are kind of tips and then also pitfalls to watch out for when you're learning to do PAE. So most importantly, at least this is what I try to tell the doctors that work with us, you don't want to do any damage. So access and closure to me is like, yes, the cases are challenging, but when you're doing this, especially in an outpatient setting, you don't want them to have any complications. So going back to the basics, considering where you're sticking the artery, you don't want to do a high puncture. You want to dissect thoroughly in the beginning because that's going to help your closure device. Select the right catheter to start. So to get up and over, we are almost always doing femoral access. We'll use a C2 catheter to start, go up and over, and then create a Waltman loop to treat the ipsilateral side. So positioning of the C-arm is also very important because it's going to splay open the pelvic vasculature really well. And if you do that consistently, you're going to be able to use your anatomic landmarks. So we like to do it about 30 to 35 degrees LAO when you're on the left side. So this is just kind of going into that. So when you're setting up for your hypo run, so now you're up and over, you're setting up, getting ready to do your hypogastric run or internal iliac run. So as I mentioned, we wanted about 30 to 35 degrees oblique LAO. What we use for landmarks is, let's see if you can see this. So the tip of the catheter, we wanted it positioned at about 12 o'clock. If it's starting to turn flat and going beyond that 12 o'clock position, you're probably too biased in the posterior division in that superior gluteal artery. And then we want the obturator foramen to be at about 6 o'clock. So when you're doing your injection, we'll typically use a 10 cc syringe of contrast at about 70% dilution. We start rather slow and then ramp up. You don't really want to contaminate down that external iliac artery. And this is one of the runs that we'll carry out a little bit longer so you can get all the detail. So having that precise catheter placement is really important. So here's a run here. Let's see here. So catheter placed at the 12 o'clock position, you're carrying it out towards the end. I have slides that go through each branch in this vessel, but in order to go through which each branch is, you need to be able to do an adequate hypogastric run. So once you do that run, you want to interpret the run. And here it's really helpful to go frame by frame, identify all the vessels. If you identify the vessels that you know are always there, then it makes it a lot easier to find which one is the prostatic. So review the run, go frame by frame. That will help you look for where the vessels are originating, because oftentimes there are double densities, and it can help you find where those origins are. So relevant branches are going to be the superior vesical artery, obturator artery, pudendal, and middle rectal, also inferior glute as well. So here, this is that same run that we just did, but just color-coded now, where it's going to show you each branch. So the yellow one is going to be that superior vesicle. The pudendal is going to be swinging in this oblique orientation. It's going to swing posteriorly, then come anteriorly to supply the penis. That's that one that's in this kind of orange color. Obturator is always going to be that inverted Y, where it's going to drape over the obturator foramen. It can arise off the external iliac artery, and that's something you're going to see, like an empty pelvis sign, is what we call it. But when it does arise from the obturator artery, which is a type 3, it will swing lateral and then come medial. I don't know if some of you guys were in the live cases, but we had a type 3 on one of the sides. And then middle rectal artery is important to identify because it often gets confused with the prostatic. It's going to be further posterior in the pelvis. It almost always arises off the internal pudendal artery, but it stays posterior and basically never really goes past the anterior margin of that obturator foramen. So that's what this like teal color is right there. And then in between that superior vesicle and that obturator artery is going to be your prostatic. So after you've done your base catheter run, we kind of like to break it up. You have staining versus no staining of the prostate. If you have staining on the prostate, then you kind of already know which branch you're targeting, right? But sometimes when there's smaller glands or there's peripheral vascular disease, sometimes you don't get that staining. You kind of have to work down an algorithm about which one's more likely or less likely. So this is kind of how we like to work through it here. So you've done your run now through the base catheter. You're switching to the microcatheter and microwire, and Dr. Bagla is going to go over some of the advanced techniques on how to do that when you encounter difficult anatomy or difficult takes-offs or vascular disease. But now you'd switch to your microcatheter at this point. He'll show you probably some shapes of the wires, whether it's a C or an S, depending on what you're encountering there. So once you switch to your microcatheter, you want to make sure that when you're doing runs, you're not over-injecting, because you really just want to see what's in front of you. I have a couple of advanced maneuvers here, and the case that I'm showing you is a case that I just did last week, but this maneuver, mastering the microcatheter engagement. So a lot of times when you're in a type 1, if it is the prostatic, it's going to be the last branch off it. So you're going to have umbilical artery, superior vesicle, then it's going to be the prostatic if it's a type 1. So doing a pullback run, which that is you have the microcatheter and you're injecting contrast just enough so you see what's in front of you, and then you slowly drag it back till you opacify that prostatic artery. It can really help you out, because if you're injecting really forcefully in the beginning, you're going to reflux back and you're not going to know where everything is. Common pitfalls to avoid: base catheter orientation. You want that base catheter facing towards that lateral wall, so it will actually buttress your microcatheter and take you to the anterior wall, because the prostatic's almost always going to be off that anterior wall. So here is, so this is that very same anatomy, that same case. We got into the type 1. This is going to be the umbilical and superior vesicle, and then you see a third branch as a pullback, which is going to be the prostatic. And you don't always get lucky like this in this case, but I was able to pull back, inject, and then advance into the prostatic. So that first branch going very anterior, umbilical. That next branch over is going to be going to the bladder. You start to see this ghost here, where that's the prostatic. And when I get that maximal opacification, I actually push forward, and then now you can see we're in the prostatic artery. And this is just a 2-4 prograde. It's nothing too fancy or too crazy here. So targeting the inferior vesicle or prostatic artery, So same idea. The technique with the angiogram is really important with these cases. So you don't want to just jam your syringe and just reflux everything back, because then you're not going to get a true sense on what you're dealing with. So what I like to do is start really slow and then kind of ramp up towards the end to see if there's any collaterals that I'd be worried about. And actually, if you go back to that case, there was a collateral that looked like it was running through the prostatic, and I'll go over that in just a minute here. So confirm you're in the prostatic artery. So some tips that's going to tell you that you're in the prostatic. You'll get glandular staining. It should be anterior to that obturator foramen. We talked about the rectal arteries will be posterior to that obturator foramen. It never dips below the pubic symphysis. The vessels usually have these micro tortuosities, and then you get that nice blush. Usually doesn't cross the midline, with one caveat: if they have peripheral vascular disease, you can have one side supplying both. Warning signs of non-prostatic arteries. So talked about that rectal stain posterior, and then also being vertically oriented and tubular. That is not going to be the prostatic. So this is kind of just running through that whole case again. So so we did our hypo run, obturator, pudendal, inferior glute, superior vesical umbilical, and it actually was a type 1. It was this branch right here, and you actually see it, and when you carried it out, you saw a little bit of staining. We get in, here's that running through the prostatic. You actually see glandular staining, but then you see this collateral running through, and you actually see it actually does eventually collateralize with the pudendal artery. So that would be dangerous if you had embolic go down there. So there's two ways you could deal with it. You could either coil it, or if you can't get far enough down, then you could give nitroglycerin. Oh, sorry. So what I ended up doing here is I coiled the vessel, and then now all you see is prostate. So choice of embolic, there's not really one embolic that we use, but it's somewhere between 100 and 300. We'll use 100 embozine, 200 hydroborol, 1 to 3 embosphere, but somewhere in that range. We mix it to a 10-to-1 dilution to prevent clumping. And really, when you're doing these injections, you kind of got to keep a forward steady pulse to basically keep that standing column. So I'm constantly pressing, and if I want to let up on how much I'm pressing, I actually just reduce the frequency. And if I want to increase on how much I'm pressing, I just increase the frequency rather than push harder or lighter. And doing it that way, you can kind of avoid opening up those collaterals. So that kind of goes with this right here. And then after we follow with the beads, we will follow with a gel foam slurry. And that will allow you to really get stasis in that parent vessel so you get a good ischemic effect, because that's really the goal. And when we're doing the gel foam installation, we're using a 1 cc medallion because it's really thick. So we'll use that. And that will be our endpoint there. So once we see it's static there in that main prostatic artery with the gel foam, that will be all done. Go to the other side. So key takeaways: beads, you want to get distal, you want to control the embolization. If there's those open collaterals, you either want to address it with a coil or nitroglycerin. Gel foam afterwards, the dilution's 10-to-1, 1 cc medallion for that gel foam installation, and then obviously vigilance. And then I have a little bit, just 2 slides on what's to expect afterwards or follow-up. So normal recovery with these patients, and anyone who's done these would know, they basically have this is like their post-embolic syndrome. So frequency, nocturia, dysuria. Patients who are susceptible to going into retention, like they've required a catheter in the last 45 days or have a very high PVR, can go into retention in that 1-week period. So those would be patients that we would consult on potentially pacing a Foley catheter if they've meet that kind of criteria. They'll get their maximal improvement. They're probably about 60-70% improved at a month, and then at 3 months, they'll get their maximal improvement. So in that same vein, we usually like them to follow with their urologist at about 3 months after the procedure, where they'll have their maximal improvement, and to kind of make us look good too. But they'll check post-void residuals. They'll do a new IPSS, and then we'll also, if they were following their PSA, we'd like them to follow 3 to 6 months afterwards, because if you check a PSA within that acute phase, it's actually going to spike. And once you get to that 3 to 6 month period, it'll be a fraction of what the initial PSA was. Potential issues to look out for: prostatitis, UTI, tissue sloughing or passage, and other complications. If they're going to have non-target or related to the penis, it usually happens like 5 to 7 days after the procedure. That's all I got. Thank you so much. Dr. Bagwell will be next, and he's going to show you all the high-end trick.
Thanks very much, Alex. I'm sure there'll be plenty of questions at the end, so look forward to that too. Great pleasure to invite Sandeep Bagla, who is going to talk us through the challenges and give us a few of his tips and tricks. Thanks, Sandeep.
Thank you. Great tips and tricks, Alex, already. Good imaging, good angulation, start slow, inject hard, later. The only thing I'd add, which I'll show you here, is our primary shapes, like Alex mentioned, are a C shape and sort of an S shape. So a C is where you just take your distal wire tip and make an angle where the width of the tip to the longitudinal portion of the wire is about 3 centimeters, maybe 2.5 centimeters. So that's how far you have back you have to bring the curve. And the S is a contralateral secondary curve you make behind that C. I will tell you that the C works almost always in a type 1, an S in a type 3, and a C and or an S in a type 2 and 4. It just seems to work based on angulation. So I'm going to go through tips, tricks in 10 minutes. Here we go. Things you have to know and 7 scenarios that I think are what really make PAE difficult. So you got to know your catheters, you got to know your wires, whether or not you like to use balloon occlusion. We typically do not. We typically don't use anti-reflux catheters. It's already difficult enough to get your catheters distally. Our favorite wires tend to be wires that offer easy shapeability. They hold their shapeability. They can be reshaped. Microcatheters that are 2.0 and 2.4 can track over them. And the microcatheters that we use tend to have the compatibility to both the coils and beads we want. So we end up landing on 0.16 or 16 Asahi Meister wire is probably our most common wire. And then we look for a wire that has characteristics that the Asahi Meister does not have. And that is a very sharp double angle wire, which is made by Terumo or Asahi or multiple different manufacturers. We typically do not go down to 1.7 catheters and below just because of coil compatibility. And like Alex mentioned, we typically do our cases femoral, not radial, just because we like to avoid even the possibility of having stroke as a risk. He went through anatomy, and I will tell you this. There are pretty much 3 things you have to look for: accessory supply, variant trunks, and dangerous collaterals. So when you see something like this, and this is in the type 1, and it grows across the midline, and it's like an egg, but on its side, you're in the bladder. So if you see something, always remember that image in your mind. An egg on the side, you're in the bladder. If it looks like an egg and it's vertical, your odds are you're in the prostate. If you see this type of variant, and you have something where you're seeing, and let me see, get this pointer going here. Should be here. Okay, great. So here's some prostate staining. It's a type 1, but if you see any branches going below the level of the pubic symphysis, tip number 1, do not embolize these. This is actually a rare branch that comes off a type 1. It is an artery to the vas deferens and then ends up supplying the testicle. And I've seen cases of people embolizing this artery to embolize the prostate, get reflux into this branch, and end up with a testicular infarct. So anything below the level of the pubic symphysis, do not touch, okay? So if you see across the midline, bladder, if you see straight branches that on an oblique angiogram are posterior to the prostate staining, then you're safe because those are rectal branches and they're generally safe to embolize with roughly 200 micron particles. And this is another example of a collateral going through the prostate and going below the level of the pubic symphysis. And this is just filling an internal pudendal collateral going to the penis. Okay, so when I look at the anatomy and where I could get tripped up, I'm always doing what Alex did, naming those 5 arteries. I always start at around 1 o'clock on a screen on the left side, and I go superior gluteal, inferior gluteal, internal pudendal, obturator. Then the easiest branch for me to find is always the umbilical, because it's this straight looking branch, just like this, that comes down over the top of the bladder. Then I look between the internal pudendal and I look between the umbilical, and the prostatic artery is always there. I have never seen it outside of that arrangement, ever. Even when it comes off the leg and it goes all the way back into the pelvis, it still sits in that anatomical location. I've never seen it. I've also never seen a prostate go below the pubic symphysis, and this is in Our practice does 30,000 embolizations a year. We've never seen it. So my point is, use those things to say, I'm going to avoid those pitfalls, because then you'll avoid non-target embolization. This is the biggest key, is you want to avoid non-target to the bladder. It can tolerate a little bit of embolization, but not a lot. The rectum can tolerate a fair amount of embolization. In fact, in a case like this, if my catheter was here, I'd give nitroglycerin, embolize with beads, maybe a little bit of beads would go in here. I still would follow gel foam and cover both of these arteries. And in this particular case, like Alex described, I would not embolize this without coiling this large collateral first. So big tips for those types of situations. Okay, 7 scenarios which make PAE hard. About 7 years ago, Ari Isaacson and myself reviewed 260 cases, and we looked at every type of prostatic anatomy, type 1, 2, 3, 4, and 5. And we said, which cases are the hardest, and what predicts the hardest case? It turns out that I thought it would be type 1 anatomy would be the hardest. It's not. It's tortuous iliac arteries. And so then we thought, well, radial access would actually reduce that time. Well, we did about 30% of our cases radial at that time and 70% femoral. It didn't make a difference. Regardless, tortuous iliacs. So when you're dealing with a case like this, you have to immediately think in your mind, am I going to do the right side first, maybe with a SAS catheter, or can I get something over, and when am I going to consider putting a sheath in? So when I look at a case, as soon as I look at the iliacs, if the right common iliac is concave towards the liver, I'm thinking in my mind, I'm going to be using a sheath. Why is that? Because when something's concave, it doesn't want to go from left to right very easily. So in my mind, I may still do the right side first, but I may want to decide that I'm going to put a sheath in. And so in a case like this, where the right common iliac is concave, I could get a C2 here, and this took a lot of struggle to get into this internal iliac. I used a glide wire, then I brought the catheter to here, then I used a stiff glide wire, then I brought this catheter here. But you can imagine my torque ability for a microcatheter is not going to be great. So now that I have my catheter here, and I need to get into this type 1, here's type 1, 1 branch, 2 branch. It's always the 3rd branch off the type 1 when it's a type 1. I don't have any real torque ability. And so this is something you have to really pay attention to, this C shape. Where I find most IR struggle, believe it or not, is this, getting up and over and getting their base catheter to a good position. So this is my approach. If I can't get a C2 over, I go to a SAS. Then I use a glide wire. Then if I need to, I use a glide catheter. In my mind, I have a rule. I never do an embolization through a glide catheter. Because after I put the microcatheter and I get to the perfect place and I'm about to coil something, the whole thing falls up into the aorta. And then I'm mad at myself, like, why did I do this to a glide catheter? So then I switch from the glide cath to a support wire, either a braided wire or a stiff glide wire. Then I put a braided catheter, and if I have a good support with a braided catheter, like a C2, MPA, anything like that, I go ahead and do my case. If I'm worried it's going to pop out, I put a sheath in. If I'm really worried, I put a sheath all the way down the external iliac artery, and then I sneak into the internal. All of that is important because if you do a PAE, it is I would say it's one of the few cases in IR which requires such patience and going through in a very algorithmic way. And when people go off their algorithm, they end up getting really frustrated, they lose their hand skills, they're not really in the right place, their imaging's not great, so have your methods by which you can get up and over. Now, in cases where you can't get up and over, and you can only do the right side, like Alex mentioned, making a Waltman loop, everybody probably knows up and over the bifurcation. But believe it or not, you can make a Waltman loop in the right side. You can form a SIM2 catheter in the right side. So if you form a Simmons 2 catheter, you have a lot of extra support. And in a case like this, where after you get all the way over, this was another case with tortuous iliacs, once you get all the way over, now I'm dealing with an obturator with a really difficult origin. And when you need to get into these cases like this, where you're going to be making 1, if not 2, full loops with your microwire, if you don't have back support with your sheath, you're never going to be able to get all the way down here, coil this rectal collateral, pull back, and then treat the prostate. So biggest lesson, hypogastric arteries, internal iliac arteries, use a sheath, go quickly to it. A 40-centimeter sheath is what we typically use from Terumo, Cook. They're all kind of the same to me. Okay, when you deal with an acute type 1, everybody has this thing where if this artery comes off at 90 degrees from the parent artery, remember superior glute, inferior glute, this is probably a big middle rectal, this is an obturator, and this is probably your prostatic artery coming off this little aneurysmal dilatation of a type 1. Well, when this angle is like this, it's very acute. So what does everybody want to do? They want to bring their Waltman loop down or a ruck, and they want to point it right into the ostium. And I tell people, don't do that. Everyone thinks if they put the base catheter pointed right at it, it works. Well, this is what happens when you do that, okay? So on the right side, it's what everyone calls like an extravaganza, right? Where your contrast is now in the wall of the artery because you want to take your C2 and you want to put it here or whatever base catheter you have. And when you go to do your injections or you come out with your microwire, you're coming out with so much force. And so you're high likelihood to spasm the origin, cause a dissection, et cetera. And this can then be subsequently a very difficult artery to get down. Now, we were able to navigate this, but if you had a choice with this case, this is how we ended up navigating it. So we took our base catheter, leave it away on the contralateral wall, and then drive our wire like this. Why does that work? Because I only have this much wire in, such a small amount of wire with this Asahi, but this microcatheter really has no other place to go. It's going to come around here, and as soon as it hits this corner, it doesn't want to prolapse. It might want to prolapse here, but if I have the wire here, what happens is this uses the lateral wall for support. And just by way of example, just to show you this, the amount of support, you can see I'm moving the microcatheter back and forth, and it's still not buckling out. And so you can get a lot of support when you balance off the lateral wall. And this is another example where, you know, you're here and we're using a SAS catheter. But again, the tip pointed away, use the lateral wall, and use that sort of gentle C to just drop into the artery. Here's what I consider a really acute type 1 with associated disease. So you see this beating of the artery proximally, and there's an osteal stenosis. And then after getting the wire in, you see how many loops you have down here. You need support, but you can't take this base catheter and shove it here and expect not to dissect the origin of this artery. So this was my poor attempt at PowerPoint of drawing little blue dots, but you get my point. So point away, acute type 1s. The other tip and trick is many patients have hip arthroplasties. So when you run into, we've done difficult iliacs, we've done acute type 1s, many patients have hip arthroplasties. So when somebody has a hip arthroplasty, oftentimes you'll see the artery just really later on come down towards the prostate, but you don't actually know where this artery came from. If it's a type 1, you almost always know. But if it's a type 2, type 4, type 3, oftentimes it's behind here. In this particular case, there may be a type 3 because there's a branch here off the mid-obturator. So what I say is do your run, rule out a type 1 first. After you rule out a type 1, just like this, put your catheter in the anterior division distal to this type 1, do a run. If the artery, if you see prostatic staining at that point, just go to an AP and you'll see the branch. So now when you go to an AP, you can just pull that branch right off the prosthesis, but here you don't want to be feeding your wire in and assuming that you're actually staying in that lumen. Okay, tip number 4, what I call the double density sign. Everybody looks at angiograms and DSA. Very few people go back and look at the unsubtracted runs. When you go back and look at an unsubtracted run, you can tell that this artery, which is the prostate, doesn't come off here. It swings posterior and comes off here and overlaps with the pudendal artery. And so you have this little double density right above the laser pointer. When you have a double density, you can utilize that to your advantage and use the contralateral oblique view. So when you're in this view, everything on this side of the screen is posterior. Everything on this side of the screen is anterior, just like when we do nephrostomy tube access or any oblique imaging. But when you go to the contralateral view, everything anterior is on the right side and everything posterior is on the left side. So what I do is I put my catheter right here. I say, oh, I inject. This artery is in front of me. Now that I know it's in front of me, I go to a contralateral view and then I see this sort of nightmare of an origin. And this is not a great origin to be getting into. But in any case, this is what we did. We brought the base catheter further down. We used a double angle wire and got around this bend, and then we got our catheter down. Once I get my catheter in here, then I go back to the ipsilateral oblique and inject, okay? Same thing here. Sometimes when you do these runs, you have a type 1 superior vesicle, and then you have 2 branches here. I dare anybody to tell me which of these 2 arteries is the prostatic artery. I have no idea. But you know what I could do? I could put my catheter right here, do an injection. Both arteries will be in front of me. After both arteries are in front of me, I go to a contralateral oblique. You see how one comes off one wall and one comes off the other? I'm on the right side. So that's anterior, that's the prostate. That's posterior, that's middle rectal. I've never seen a prostatic artery come off the posterior wall of the pudendal artery. Doesn't happen, because anatomically it has to travel to the front of the pelvis, and the pudendal artery at that point in the pelvis is posterior, not anterior. Okay. This was the concept behind curves in wires. So you could Eva's got 2 minutes.
Last 2 minutes.
Okay. So you know when you come out of this catheter with your microwire, everything's going to want to go lateral. Nothing is going to want to go medial into this branch. I mean, this is kind of a nightmare situation. Nothing is going to want to stay medial. I don't care how much device companies make. They don't sell a wire that goes medial. Nobody. It doesn't matter. So what happens is any shape you put on this, even if you have a really tight headliner wire, you're going to sit there and you're going to spin it and it's going to whip and whip. And everyone's going to say, oh God, I can never stay on this medial wall. So when you need to go against a curve is when you use an S shape. So I used to waste so much time like making a million shapes on wires, and I learned this trick during shoulder embolization cases like almost 10 years ago. And I realized that if I take this shape and I make the opposite, which is a secondary curve behind it, the wire will just go to the other wall. You leave this secondary curve in the microcatheter. You only bring the distal curve out, but what happens is the proximal curve takes the catheter and points it the opposite direction. So that's what's so nice about these flexible microcatheters is that shape allows you to do that. So that's when you go to an S curve. My last shape, really, my last issue is when you have these hyperacute angles where you go really 180 degrees away from you. Everyone says I'm going to use a Swift Ninja. In the United States, a Swift Ninja is like $2,500 US, so we don't use that. So I would change to a shaped base catheter. So this is an example where we use a TCBNK catheter from Cook. It has a really acute curve. We put it distal, pull it back, engage the origin, put a microcatheter in, and then you can get into this. So that's a good example. And the last trick is when you have a horizontal upward turning internal iliac. These are a nightmare. And when you have this, I tend to like to use a SAS catheter as my shape, unformed. Point the base catheter upwards, use that lateral wall, and come down. And you can say this is not an easy case, but we got down no problem. And that's probably my last tip and trick. With that, I'll finish.
Time is up.
Thanks very much, Sandhu. Thank you. Like I said, guys, we keep the questions to the end. I'm sure there are plenty of them. The next one, I believe, is a video. Yep. Okay, let's run.
Priyanka, her post-cath lab. This is the IPD setup of Dr. Priyanka, her post-cath lab recovery room. She is doing the checkup of her prostate embolization patient who is very happy post-procedure and is glad that he did not end up with a TURP and she could do it with a catheter. She started wondering after that, I now and then get a prostate artery embolization patient maybe once in a month. What do I do to increase patients? How do people get more patients? And with that thought, how to market herself or how to market and create awareness about this procedure to people so that they can visit IRs and even her OPD individually, she called up Dr. Sandeep Bagla because she thought he is the best person to answer this. You know, he runs the prostate centers so successfully, he is expanding exponentially and he should have a very good strategy with respect to marketing. Dr. Bagla told him that for any kind of marketing or business expansion, the fields are grouped into two basic strata. One is business to business and second is business to consumer. When it comes to business, the two main referring clinicians would be urologists who get most amount of these patients as subspecialists who treat it and GPs or family physicians. But he had to cut it short because he was a bit occupied. Handling so many centers is not an easy job. So he said, let me divert to Dr. Gaurav and he can take it from here. So delving into the topic further, as you saw, yes, business to business is a good pitch and you can approach urologists, family physicians who get loads and loads of patients with these problems. Urologists, you can either expect to be a supportive or a
You can either expect to be a supportive branch to theirs, because if you want to compete, then don't expect referral. Or you can even do it in a collaborative manner. Let's come back to supportive. Well, if I have to pitch to a urologist colleague in a hospital and we are not really, I mean, there is still that turf war kind of overlap or problem, there are high chances even in selected cases where he feels he needs an IR, he may not refer it, because he knows that you are just there for as a competitor and not as someone who wants to contribute. And there you can pitch them, not every case to be sent to you, but you can tell them, okay, look doc, you have your, I would say TURP is still the gold standard, your uroflowmetry results are still better, long term recurrence probably much better. So what I am telling you is, give me the patients that are difficult for you. Give me the patients that are elderly with comorbidities, lot of anesthesia, surgery risk, not worth it. Give me the patients on anticoagulation or antiplatelets where switching them off would be risky. You will feel it's not a huge number, but it is a decent number at that age, mind you. Give me patients with large prostates. In my experience dealing with large prostates, it's easier to say HOLEP can be done even for 100 gram plus, but practically many urologists are wary of doing that due to logistic reasons. So you can always pitch and they would be ready. Tell them it's like a pre-op embolization. Let me shrink it and then it becomes easier for you. They can send to you patients with recurrent symptoms after TURP, where really the patient, at that kind of age and mindset really goes after them and they would want a bailout, giving some option to that patient. Patients who desire sexual functions, they know no matter how good they are, there can be risks, and if a patient is really, if they are scared of the legal side, they would definitely refer to you. Hematuria, if one of the codominant symptoms, definitely we win over. And urinary retention, you can urge them to play it safe and give it to you first, and then if the catheter Foley's is not getting removed, then they can come in and tell the patient, look, this is anyways a difficult, probably your bladder muscles are exhausted based on the urodynamic study, so let me again try. So if you say this, there is high chances you might get a few patients. We know the prostate center models where urologists and IRs work in tandem in collaboration as partners, and then urologists are happy referring, and I would say both of them get the maximum volumes and quality work SOPs because of those volumes. So not a bad idea if you feel that it's best for the patient as for both the teams. B2B, the other group was general physicians or family physicians. You can definitely contact them. Awareness is a good start, because I have seen their attendance to be in huge numbers, nearly 90% plus in all CMEs that are organized for them. Whether it's for credit points, whether it's for staying updated, take advantage of that. Have your own personal relationship officer. One thing which works, and probably the only thing that really works in terms of conversion, is let them, one of course is incentives. And skip the second point, let them have ownership, always update them, they like that, send the patients back after you treat them for further medical management. But without incentives, without a simple greeting or a note saying thank you for referring this patient, without a festive visit and a greeting card, nothing else is going to work. I mean, for those who are smart will understand what I mean, but yes, B2C, approach the patients directly. You can do it with paid ads, which would be some spend from the pocket, but yes, if the returns are calculative, you can go ahead with that. But this is organic social media marketing or organic awareness campaigns is something that is not explored to that extent. Minimum organic presence is required in Google My Business and your own website. That is bare minimum that's required, and you should have that. But I have seen and experienced the success that YouTube can give you in terms of both your awareness campaigns as well as the conversion, and I would definitely urge you to consider that. These are some of the popular videos posted between a year or two, and these are the numbers where we have reached in terms of long videos. And shorts, of course, can give you a whole different ball game. You can reach around 3+ crores of patients, and which probably long videos, it has to be really heroic video to do that. So shorts is something which we should leverage and now reach patients through these reels and shorts. But there is a process to that. I would always say know the result, but follow the process. And the process is in two parts. One is know the SEO algorithm. There is a way to do this. There is a search engine optimization algorithm. And it's basically very simple. It's a set of rules which you need to keep intact. Like CTR is nothing but click-through rate, meaning how good is your thumbnail, how aesthetic and clicky, so that if your patient types prostate treatment without surgery and he sees 10 videos, he should be attracted to click on your video. And but again, just understanding the computer and the algorithm but not the audience is not the best deal. Ultimately the audience, the viewers are human beings with emotions and you need to catch the emotions. For that I always talk about this steps approach where you can give them a social currency to play with. If they share your video, they appear smart on their family groups, they would really want to share, and that gives engagement clicks to the social media algorithm and makes your video go viral. T is the trigger, meaning you give them something, some information which triggers them to share it or save it, etc., based on your call to action. Sorry, based on your call to action, and helps your video too. Is the emotional response. If you put in humor or a tragic story but a real one, be authentic, it really clicks and people do like to see it longer, share it with many. It has to have practical value, otherwise you would just be one of those viral meme materials. Lot of virality but no conversion, and we don't want that. Our purpose is awareness mainly but also some conversion, so we don't want to just be just add humor and become viral. It needs to reach places. And of course the king of all social media virality, storytelling. If there is high retention but authentic storytelling, it will reach audience. No matter whether it is algorithm optimized or not, people will make it reach other people. So bank on that and it would work. With that I'll end this short presentation, not claiming to be a person who has a very large prostate embolization practice, but yes, whatever we consistent practice we have, we own it mainly to B2C version where we approach patients directly through organic marketing, mainly YouTube of course. But for any other queries, feel free to approach Dr. Bagla and his team, Dr. Alex. I saw Dr. Alex's name in the faculty. They should be happy to answer it. I am taking this extra privilege because I have seen how approachable and how kind they are in helping all of us out.
Detour from the program and listen to Dr. Gaurav there and invite Sandeep to share his experience on how to go about setting up a practice when it comes to prostate artery. Alex, you can join us as well. So take it away, guys. You're the kings.
I don't know about kings, but I'd say the first thing is I'd probably give like 3 practical tips. One is understanding what your target is and how you're going to, capture patients. So like Gaurav mentioned, and he's a marketing machine, he's not just great at IR, but he knows how to position himself so that he becomes the attractive person in the community to send patients to, whether they come direct or from another referral source. That's important, but it's equally important because when we first started, you're convincing urologists to send you patients that unfortunately, just like in the Indian healthcare system, it's no different in the US, that there are going to be conflicting economics. And understanding the data behind where, like Raghav talked about in his talk, where PAE fits in, or any other procedure that we do, and how it can benefit the patients. If you can't have that conversation of where IR fits in well to other specialties and for what patients will benefit the most, then they're not even incentivized to send at all. I would say from the business structure, the third point I'd bring up is, in America, there's an old saying that doctors are not very good business people, but I obviously do not believe that. And I didn't have much of a entrepreneurial understanding in the medical space. I did in the software space before starting our company. But one thing I did is I dug in to learn everything. And replicating what you do well. So there's a reason we do everything femoral. There's a reason we use the same wire. There's a reason we train the staff the same way. Because I don't care that somebody tells me, oh, I found this really new cool toy in IR, because that's what IR is, right? We all have these new toys. We just want to create a system. And when you're creating a business, it doesn't matter if McDonald's burgers are a little bit worse than somebody else's. They can make their burgers in 16 seconds and they cost 30 cents and they can sell every burger for $2. And so when you're developing a business model or plan, and no different in healthcare, if you're operating every day, teaching the staff, which I think is probably the biggest thing, mentoring your partners and or doctors, which is why we're so big on education, these become replicatable things that in a business it's not just, okay, I graduated medical school, I can operate, Sonny can do a PA, great. I mean, that doesn't matter, right, when you run a business. Patients don't even really know how good I am at PA. They honestly don't. And the urologists in my community don't know if Alex is faster or I'm faster, or they don't have any understanding of that. They know we're good people to deal with, we're trying to save costs, we're trying to have good outcomes, we're trying to avoid adverse events, and we're trying to replicate things so that their patients in the community can benefit. So the business aspect, I think that's the piece I would really study. In fact, I was just speaking to a third-year medical student about this who's, looking to potentially not just practice medicine, but do something entrepreneurial in medicine, albeit he did tell me he wanted to do, I can't see him right now, but he's right there. And he may want to do a surgical specialty instead of IR, which I think would be a horrible decision. But I'm just kidding. And he asked me, what would I do now? I said, you have to understand all of the powers at play in healthcare, right? How does he, I don't even know this involution people, I think they sell all these devices. They don't sell in America. How do they make money? How does the Indian government make money? How do insurance companies make money?
Last 2 minutes.
How do the doctors make money? And then when you start your business, you're going to make sure all those people are happy and your business will thrive. Unfortunately, nobody cares about your happiness. You have to make sure yours fits in with everybody else's. And that's business in healthcare. So I'll have Alex add in because I think it's important with our particular model about education, training, and he's really key on that.
Yeah, thank you. Obviously, I'll piggyback off of what Dr. Bagla said. I would say I interface a lot with the urologists. So when we're starting new practice and partnering with the urologists, the currency that they speak in is the data and the literature. So if you come to a meeting with a urologist and you don't know your own literature and your own data, they're going to eat you alive. So you really have to understand where PAE fits in. You don't really want to come in and say, PAE is the one procedure for anyone with an enlarged prostate, and that's the way it's going to be, because then you're not going to get the best outcomes, and you're going to lose credibility with the urologist, and at the end of the day, also with your patients. So I think those are the two biggest things for me. The other thing I would say is, at least in the United States, a lot of the IRs work just within a hospital system. And it's almost like a factory or a widget line where they take care of the patient, they'll see them for the consent, they'll see them shortly after, and then they don't follow the patient afterwards. So if there is a complication, they may not even know. I would really encourage you, especially with PAE, that you follow your patients and you be a clinician for them, because that will also give you respect of the urologists who are referring you to some of these patients, and then also the patients themselves. So I think those three things are huge factors when you're trying to develop a practice.
Thanks, guys. Thanks.
Thank you very much.
I think we should move on to the next speaker. I gather Dr. Kulkarni is not coming. Is that correct? He's there. Sorry, beg your pardon, guys. Great pleasure to introduce Dr. Kulkarni. He's going to speak to us about complications and management around PAE. Thanks very much.
Good afternoon. At the outset, I want to congratulate the organizers for such a wonderful meeting. And I'll be speaking on complications and then management, nothing to disclose. Complications we define as an unanticipated outcome of the treatment, and in prostate artery embolization it can be because of the injury to the target organ, that is prostate, or because of the non-target embolization to the bladder, subvesical rectum or the penis, or it can be radiation induced injury to the skin, excess site related complications, or contrast related complications. This is a recent CIRSE guidelines to grade the complications, in which grade 3 and above we can grade as the major complications. To get a perspective of what we are dealing with, these are few of the high volume papers. The incidence of the major complications is from 0.06% to 1.3%. That is very, very less. This is a timeline of occurrence of various complications. We should be mindful of the late complications which can occur at post 3 to 4 weeks, that is prostate tissue detachment and radiation dermatitis, even though they are rare. Excess site related complications like hematoma, dissection, occlusions are very rare, 1 to 2% of the patients. Stroke related to radial excess is less than 0.5%. The major risk factors are associated disease and the vasculitis. The ways to mitigate this is do pre-procedure imaging, understand the tortuosity, vessel wall, calcification load, and use imaging for use use the imaging to access the access site. Post-embolization syndrome is a very underreported adverse event. In one of the large meta-analysis, the incidence range from 12.5 to 45.8% of the patients. The common symptoms are dysuria, burning, urethral burning, local pain. A few of the authors have studied the influence of the prostatic size, and use of smaller embolic agents may cause more post-embolization syndrome, but the same is not echoed in few of the other studies. The management is usually symptomatic. The two of the questions is whether we should be using the peri-procedural antibiotic coverage. Why this question is because the incidence of urinary tract infection is very, very less. It is only 1 to 5% of the patients, and we don't have direct evidence that giving antibiotics will mitigate the symptoms. But however, it is very, very useful in the high-risk patients. The other question is whether steroids can decrease the post-embolization syndrome as in other embolization. This is one of the randomized controlled study in which they gave single 24 milligram of dexamethasone at the end of the arterial access site closure, but they could not find any significant advantage. This is a recent paper in JVIR, a consensus study, where all the authors felt that antibiotic prophylaxis is recommended. However, 93% of them also felt that this is one of the inadequately studied subject. The other complications because of prostatic injury can be tissue detachment. The incidence is 0.18%, is one of the high volume study, but it's one of the randomized study, the incidence was 6.3%. The main predictors are patients on indwelling catheter, larger central gland index, smaller embolic particles, and the larger embolic volumes. The patients with tissue detachment, even though they are symptomatically perform better, but they can end up in acute urinary retention requiring endoscopic bailout in high percentage of the patients. So if we have a tissue detachment, we have to titrate the alpha blockers, improve liquid intake for the patients, analgesics SOS, then wait for the tissue elimination, and if not, it requires the cystoscopic assistance. UTI or urosepsis is again not very common, 1 to 5%. Urosepsis as such is less than 0.5% of the patients. The important thing is if we suspect this, we have to image and identify the source and treat accordingly. Bladder ischemia can lead to small or extensive necrosis. It can lead to hematuria. Sometimes ischemic fragments can cause acute urinary retention. And small unperforated areas can be dealt with the indwelling catheter and the antibiotics. However, the larger necrotic areas may require surgery, but the incidence of such a complication is very, very less, that is less than 0.5% of the patients. What are the risk factors? The main risk factors is the prostatic artery anatomy itself, the smaller size of the prostates, and use of smaller embolic agents. If you have a anatomy like this, where small feathery branches are supplying the bladder along the prostate, it's one of the difficult situations. Few of the ways to come out of this situation is first is to attain as distal catheter position as possible towards the prostate. If not, try to give intra-arterial vasodilators to redirect the embolic agent towards the prostate, or use of the balloon occlusion catheters to create a negative pressure towards the prostate and deliver the more embolics, or else use the larger embolic agents. But the trade-off of using the larger embolic size particles is it can cause premature and proximal occlusion. Seminal vesicle ischemia is again the incidence ranges from 2.7 to 7% of the patients. It can lead to symptoms like hematospermia and painful ejaculation. Most of this is self-limiting, requiring no further treatment. Again, the smaller prostate size and use of small embolic agents can lead to this complication. The things to prevent is identify the artery. CBCT will be useful in identifying the artery. And once we identify the artery, attain distal catheter positions to prevent this. This was an elderly patient with 65-gram prostate, acute urine retention. We did a PAE, post-PAE on the follow-up MRI. We found the diffusion restriction in the seminal vesicle. This patient was completely asymptomatic, and this finding resolved with no further management. Rectal ischemia can lead to diarrhea, rectal bleeding. Incidence is 0.24 to 2.4% of the patients. Again, most of this is self-limiting, requiring no further treatment. We should advise the patient for fiber-rich diet, laxatives, adequate intake of the water. Then there is no case report in the literature which requires surgery to solve this problem. The thing is, important thing is to identify the rectal branches and coil them before we proceed with the PAE. This was a small superficial rectal ulcers which was conservatively managed, and we can see the resolution of the ulcers in the follow-up colonoscopy. This was an elderly patient, 123 cc prostate. We can see a communication between the inferior vesical artery and the middle rectal artery, which was successfully embolized, and then PAE was completed. Penile ischemia is another critical complication. Incidence ranges from 0.5 to 3.5% of the patients. Again, small superficial injuries are self-limiting, and conservative management is what is required. And important thing is to again identify this and coil embolize this. This was a case in the literature of superficial penile glands ulcerations, which was managed conservatively, and no surgical assistance was required. Once we coil the penile collaterals, the other adverse event can be effect on the erectile ejaculatory functions. These are few of the studies which have addressed this problem, and we do not find any adverse effect on the erectile or ejaculatory functions post-PAE. So this was an elderly patient with, for PAE, we can see an accessory central branch which was reinforcing both the penile arteries. We tried to access it through the internal pudendal artery, but we could not reach that central branch, so we injected with this catheter position, we injected 50% glue, blocked that central branch, and completed bilateral PAE. This is another similar case with the central accessory artery reinforcing the penile arteries. So this was confirmed on the CBCT. So plan was to reach the central branch through the prostatic artery, but because of tortuosity, we could not reach. So we accessed this using the obturator artery, which was relatively less tortuous, coiled it, and completed the PAE. This is another case of communication between the prostatic artery and the internal pudendal artery, which we blocked using the coil and completed the PAE. Pelvic ischemia is again a rare complication. It is because of the non-target embolization of the obturator artery. Many times it requires no further management, and this is just an imaging finding. Radiation dermatitis is a very rare complication. There is only a single case report in the literature. One important factor which we should be careful is the value of air karma, which will be there in the end of the dose report at the end of every procedure. If it is more than 5, and then we should be thinking that some complications can occur, and this can occur late, that is 2 weeks. So if it is the case, then we should educate the patient that he might have skin changes, and he should revert back to us as soon as possible. This is a high volume study, multi-center study, which has studied the radiation exposure, and the average exposure is 12.3 millisieverts to 17.8 millisieverts, and they did not find any radiation-related adverse events. This is a case of PAE, left prostatic artery was arising from the obturator artery, which was arising from the CFA. Right prostatic artery had a communication with the middle rectal artery, which was a difficult procedure, small prostate, with air karma of 6.8. This patient, after 2 weeks, complained of withering of skin from the palmar aspect. We found, even though it is not a common site, if you take too many obliques, this can be a site of exposure, and this was conservatively managed with no further treatment this thing requires. These are a few of the best practices, like use pre-procedure imaging to understand the complex anatomy, intra-procedure use CBCT, use ALARA principles, use low-dose protocols, prioritize AP views over the oblique views. To conclude, major complications are not common. Think of a complication whenever there is persistence of symptoms beyond 10 days. intense pain during or immediately after PAE, acute urinary retention, or new onset erectile or ejaculatory function, and be aware of the renal complications which can occur late, and always educate the patients about the complications, and lastly, work closely with our urologist and surgical colleagues to manage this. Thank you.
Thank you very much. Thank you. All right, guys, I think we're moving on to the last presentation, which is from a urologist. Welcome, sir. It's my great pleasure to introduce Dr. Ananthakrishnan Sivaraman, sir. Thank you very much.
Good morning. I'm Dr. Anand Sivaraman. At the outset, I must thank the ISVIR team. Could I get my slides on, please? ISVIR team, and especially Dr. Jayaraj Vishwanathan for asking me to come and talk today. So I've been given a kind of a job here to talk about the basics of transperineal biopsy. And before I start, I'd like to ask, how many of you are doing prostate biopsies? I think all of you are urologists. Yeah, great, a good number, okay. How many of you are doing transrectal? Transperineal, anyone? That's only one. He's a British guy, yeah? Yeah, so the Brits have moved away from transrectal into transperineal, and they call it the Trexit, moving away from, like Brexit, moving away from transrectal to transperineal, yes? So let me give you a slight basic overview of what we're dealing with here. Why should we shift to transperineal biopsy, right? Transrectal, I've been doing transrectal biopsies for, I would say, from 2003 onwards. And then 2019, I moved over to transperineal biopsies. Why should we move to transperineal biopsies? Number one, it's a clean procedure. We don't go through the transfecal route, right? So it's a clean procedure, sepsis is almost nil, minimal antibiotics or no antibiotics, and then relatively less local complications, and access to anterior aspect of the prostate. Like a lot of you have seen that BK has come out with a triplane probe, and then you can do an end firing where you take anterior biopsies, but oftentimes we don't get access to that sort of a probe. So if you need to access the anterior part of the prostate, transperineal is a very good way of doing it. And retention rates are slightly higher than transrectal, and sometimes you may need anesthesia for transperineal. So what do the guidelines say? A couple of years ago, the European Urology Guidelines came out with this slide that said the indication for prostate biopsy is a transperineal feasible, and if it is, it's the first choice. Do transperineal biopsy. If you cannot do transperineal biopsy, then consider transrectal biopsy. I think this is a key slide here. And we're not talking about, the template biopsies where you have to give them anesthesia, give spinal, keep them in the hospital for a day, and then 50 punctures in the perineum and then get your prostate biopsies. We're talking about freehand MRI cognitive transperineal biopsy. That's something done under local anesthesia as an outpatient procedure. So this is not what we're talking about, right? This is something that happens when they use a brachytherapy template. This is something that we're talking about, right? What sort of equipment do we need? And number one is you need an ultrasound that supports a biplane probe. You can either have, I'll talk to you about different probes, transverse and sagittal array. They can either be convex or straight arrays are acceptable. You need a stabilizer. At least in the initial days, you need a stabilizer. And basically, you need a mindset change, right? That's key, right? So these are the types of probes, end firing, side firing. This is the BK I've put in. But BK comes out with their own stabilizer. You can use this to get transperineal biopsies. Well, the Cambridge guys have come out with something even simpler. This is just a coaxial needle, right? It's called a CAM probe. All you need to do is align it in front of your array and then go ahead and take your biopsies. I'm kind of partial to transperineal biopsies with a precision point. This is an American company that does this precision point device. And it's kind of a stabilizer that helps you get your biopsies right. And we also have local makes of this. It's an autoclavable entity, and it's been reverse engineered here in India, where you have, that's one of the right is precision point, the blue one is the local made 3D printed entity, and then you have an autoclavable entity as well. And you can use it in any number of machines. You don't just need a BK or a Hitachi to do these things. You can do it in most ultrasound machines which have a biplane probe. So if you're already doing transrectal, there's a very small change to go into transperineal. And I would advise never ever do a transrectal with the transvaginal probe that you get, that you have to twist the probe left and right and do a transrectal. That's kind of gone. I think we should move away from that, right? You have to have a biplane probe to do a transrectal or a transperineal biopsy, and then you need to do it nowadays with the transperineal. So the first step and the most important step when you're doing any biopsy, especially because the transrectal ones come with the needle just close to the area, and you don't need to align it. But when you do a transperineal, you need to align the needle so that it kind of works into the exact area that you need to, right? So I usually do it. This is us doing it and then showing you that just for a demonstration where exactly you need to see the entire length of the needle when you're doing transperineal, primarily because the distance from the skin to the prostate is about 4 centimeters, and transrectal is about 4 millimeters from where you put the needle and it goes into the prostate, right? So local infiltration in the perineum, this is something that needs to be done. This is pretty simple. It's not multiple punctures in the perineum, just 2 punctures, one on the left, one on the right. And I'll quickly go on to this slide where we infiltrate local. Now when you're doing transrectal, you would do an anterior aspect of the near the periurethral area and the prostatic base and the fat pad in the prostatic base. Here it's only anterior because all your needles are going into the anterior aspect. And here you see us go into the space of Alloway after Matthew Alloway. He is the guy who invented the precision point device. And this is a very nice area to give your local infiltration. Primarily because what happens with this is the entire area gets covered, and in fact it diffuses onto the other side as well. So when you do the left side, the initial pain is higher. Then I usually go the left and right first. And then when you do the right side, the pain is much lower. The patients don't get a lot of pain at all. So, I'm sorry. So what sort of template do we use? This is a mindset change that you need to have. When you're doing transrectal biopsies, you'd go apex of the prostate, mid-gland, and the base. Here you need to change slightly. You go anterior, mid, and posterior, right? In that you do lateral or parasagittal and lateral. So this is the mindset change that you need to do when you're doing, and suppose it's a very large prostate, you can also take separate biopsies from the base of the prostate. So a very important slide. I always tell the prostate anatomy, the area that's important is like the horns of a cow. I'm quite certain all of you have seen the horns of the cow on the lateral. This is what I'm trying to say. Everything, most of your biopsies in this area is what you need to take, and you need a very, very good radiology friend who does these kind of template markings for you. You need to be pretty good at reading an MRI yourself, but I'm sure the radiologists are far, far better than urologists in reading MRIs, and I always take their help when doing these sort of template markings. So the precision study showed us that you cannot do a biopsy without getting a multiparametric MRI beforehand. The recent PRIME study in 2025 showed us that a biparametric MRI is as good as a multiparametric MRI. So you don't necessarily need to do multiparametric in all your cases. In Chennai, we do not do a prostate biopsy without getting an MRI beforehand. That's mandatory nowadays. There's no high PSA, direct biopsies, out of question. Right? So what sort of template do we use?
Last 2 minutes.
Yeah. So what sort of template do we use? I'll quickly skip. And we use, and give you a couple of videos about how we take the biopsies in different areas. If it's an anterior, then you would tilt your angle slightly, go up and take this biopsy and go in, right? You see that needle coming in. Every segment should show the needle, and biopsy done. Quickly, go to the next one, right base. And again, if you need to go to the right base, you need to travel a little bit into the prostate. go mid-level of the prostate and then take your biopsy. You have to understand that a 5 millimeter part of the needle or the biopsy gun doesn't take the biopsy. So if you pass point beyond the prostate, you want to take something at the base of the prostate, that's acceptable as well, right? So left anterior medial, again, we should be in the anterior aspect of the prostate, very, very much anterior. And then this is medial aspect. So the transverse entity, the array shows you whether you're parasagittal or lateral, and the sagittal entity shows you how anterior, mid, or posterior you are, right? I'll quickly go on to the data. So what does the data say? Do we need any software fusion or hardware fusion? I think it's more or less equal. Cognitive fusion is reasonably good. If you have cognitive fusion, then slight incremental steps you would get software and hardware fusion. What about data? Randomized controlled trials, 3. This is the PROBE PC. This is an American study. Do not find a major difference. Again, these are talking about complications. Again, the PREVENT study, again, by Jim Hu and colleagues, again from American study, but they didn't find a major difference. But again, he argues in a research letter at JAMA Oncology that transperineal prostate biopsy should be the way forward.
Time is up.
The next one is the PERFECT study. This is a French study, not adequately powered. They didn't find a huge difference in cancer detection rate. And the last one is the major one. The Lancet Oncology one came just last year. They did find a major difference, a significant difference in the amount of cancer detected with transperineal biopsy rather than transrectal biopsy. And again, multi-analysis, including 10 RCTs, did find transperineal biopsy to be better in cancer detection plus complication rates. This is our paper, came out in 2022 with data from 2019 onwards. And we've moved on to transperineal, and there's no looking back. I really haven't seen a patient with sepsis in the last 5 years after transperineal biopsies. But once in a while, when you're doing transrectal, you do get a patient that needs to go into ICU, and then it takes about a week of your life when a patient after biopsy goes into an ICU for urosepsis. So India needs to move to transperineal, and I think all the urologists put together cannot do enough biopsies. You guys should be doing a lot of them as well. Thank you very much.
Thanks very much. Thank you. So if you can come and join me and also invite all the other speakers onto the stage. And great pleasure to invite my friend and colleague, Dr. Mohan as well. Mohan. All right, guys, that brings us to the end of a very robust session on PAE. I'm sure there'll be plenty of questions. Now, I certainly have plenty of questions myself, but let's see what the audience comes up with. Any questions from the audience, guys? Okay, let me kick off myself then. Chaps who are performing PAEs. I didn't hear a mention of the so-called perfected technique. Just turn to the right, yeah. So perfected technique?
Yeah, so perfected technique is proximal embolization, so your catheter's in the prostatic artery or inferior vesical artery, and then following embolization where you get absence of staining, you advance your catheter further into the gland and give more beads. The reason that technique was popular when Francisco Carnaval first published it is because the bead size that we were using was 300 to 500 micron in range. So the beads would not actually penetrate into the prostate. And so in order to maximize your amount of ischemia with bead penetration, that's why we did perfected. Now that we're using beads that are half that size, and there's a great anatomical paper on BPH, and the average arteriolar size, perinodal, intranodal, in the interstitium of the prostate, which basically shows those arteries are about 150 micron in size. So now that we have that data, I don't think you need to do it as long as you start distally with smaller size beads.
Okay, and glue.
And
glue?
Oh, glue. I'm always the guy that has to debate this. Okay, so I know in India glue is very inexpensive. In the United States, one vial of glue is around $1,500 US. So it's very expensive. It costs more than all of our other devices combined for the same procedure. And here I am trying to convince a urologist to do like this procedure over a TURP that costs, you know, like nothing. And so I can't really justify that. But the other challenge is there's no real good data. The only published study on glue with PAE was from the Mount Sinai group. The only, I'd say, like larger scale study. They claim a very reasonable success rate, but it doesn't match up to articles.
Have you got space in your luggage on the way back?
Sorry? Space in your luggage. Yeah, I should. Yeah, customs will stop me with all the glue.
Okay. Audience, any questions, guys? All right, my question. Yeah, go for it. Yeah.
So my question is to our urologist. Amazing work by you, sir. Me being an interventional radiologist, I am amazed the way you are doing prostate biopsies perineally. My two quick questions are, first, have you ever tried using a convex probe and keeping it over the perineum and trying biopsy? Secondly, what about the sphincter, anal sphincter control? Does it get affected by the perineal lignocaine which you are infiltrating?
It's a good question. We've done biopsies for patients who've undergone abdominal pelvic resections, AP resections, and they don't have a rectal opening at all. So in that case, what you can potentially do is push the probe. The skin is lax there. It goes in a bit. It allows you to see the prostate, and you can take biopsies from the transperineal biopsies without going into the rectal channel at all. All you need to do is change your angle a little bit. That is possible. And I don't think the rectal sphincter is an issue at all. We're going slightly lateral and above. I really don't think we are in that area at all, to be honest.
Okay. Now my next question to the panel is, how many of you believe in doing CT angios pre-procedure?
I do it routinely.
Routinely?
Yeah, I do it routinely. Maybe I don't have to. These experts may tell us you don't have to, but I do it routinely.
Okay, and you guys don't?
I mean, I almost never do a CTA beforehand. I think, one, it's a static study, so you're not going to really be able to garnish too much information. Two, it's like if it's not timed perfectly, you may not even see the prostatic artery. But three, the purpose in which you're doing it for, if it's planning, if you're going through the case in a systematic fashion, you're going to be able to get information that's usable a lot quicker. The one scenarios where I'll consider it is if I know they've had like an EVAR and they could potentially have an occluded internal iliac, and some of those scenarios, then I might consider it. But that's maybe 1 or 2 cases in a year.
Yep.
Most of the patients whom I deal with are elderly patients, and I always do a CT before the PAE. It helps us to understand the anatomy, especially the iliac tortuosities, which is one of the very difficult steps, and the CBCT will help in understanding the prostatic proper, but the rest of the thing really helps me, so I always do the CT.
Okay, that brings me to CBCT. Do you guys believe in cone beam?
We can start this way.
No, we don't. We do everything. All those images that you saw were all on a C-arm, so we don't do any cone beam at all.
C-arm as in mobile. A mobile one?
Yep.
Oh, okay.
I've got a question to the panel here. Is it all comers prostate gets prostatic artery embolization? How do you guys choose? When somebody walks into my clinic, I've got, I talk about TURP, HOLEP, and we do everything in TURP, HOLEP. We've got water vapor therapy, resume. We do simple prostatectomy robotically, and then we do an open prostatectomy as well in very rare cases. So I've got a list of stuff, and I'm probably one of the first guys who've sent prostates for IR as well. And those cases were initial cases that couldn't have anesthesia, or they were high-risk cases that wouldn't tolerate surgery or something like that. But looking at your work is amazing. So what kind of patients would you suggest that are fit for prostatic artery embolization?
I think it's a great question, and I think for me, where you see the maximal benefit, obviously hematuria patients who've had previous, these are all going to be, of course, not great surgical cases first, but hematuria patients who've had previous radiotherapy who now have LUTs, but they're at high risk for bladder neck strictures. So for the IRs in here, you may or may not know, but post-radiation surgical intervention can portray, maybe a worse outcome. So where IR in that situation would not have a worse outcome. We also augment PAE in prostate cancer patients, not for definitive therapy, but who are going to undergo EBRT, IMRT, who have large glands and an IPSS over 16, because those are patients who are high risk for retention during their radiotherapy. We don't use it in the setting of robotic, as you know very well. The blood loss is minimal, and so there's no real significant benefit for that. In the LUTS patient, so in the classic BPH patient, it is the patients who do well are those with preserved bladder function. So the data that I think Raghav showed the data, I think, but in that data slide, the one take home is PAE works as well as TURP for IPSS improvement. But if you need a better flow rate, and you need a better flow rate in people with bladder diverticula, multiple episodes of acute urinary retention, bladder stones, those patients should get a resective procedure. Now, of course, there's the patient who doesn't want the resective procedure because they don't want the 1% risk of incontinence for a HOLEP, or they don't want a prolonged Foley catheterization. So that's fine. We may take them if they're a little bit stubborn to not get resection. But where you want to maximize flow in those patients, weakened bladder, diverticula, high risk for a complete occlusion, have surgery. People who just want a better quality of life. So I always tell people, if you want to urinate like my 12-year-old son, get a TURP. Get an aquablation, get a HOLEP, because your flow will be like, it'll hit the toilet and you'll hear him peeing from across the house. If you want to just have a good quality of life and you want to stop your alpha blockers and you really are just bothered by your symptoms because interfering with your night, your work, etc., then PA is a great procedure for you. Yeah.
Small follow-up question. Now, for instance, when you're doing PAE, you're coming from the lateral to the medial. Yeah. And when we guys do a water vapor therapy, we do the medial part that causes the obstruction. Does that make a difference in flow rates or so? For instance, the water vapor therapy, the resume that we're doing here, takes about 9 seconds per hit, and it takes about 6 hits, which is 3 minutes procedure done under local anesthesia, but targets the area that's blocking the channel. But when we're coming lateral to medial, are we targeting the area that is...
Last 2 minutes.
Yeah, so we are actually targeting based on the size of the vessels. Based on the size of the vessels and the embolic that we're using. So it actually does shrink the central portion of the gland. By total volume, it's going to be about 30%, but it's actually going to be more in that central portion.
So Mohan's got a slide to project, but in the meantime, in the UK, we go by a size criteria. So we don't like 35, 50 ml prostates. We really don't want it. And the urologist won't send them either. So we want the larger ones first, or if you have a younger patient in the 50s, very symptomatic, they don't want to take risks that we get them. So our cohort is slightly different to your regular 70-year-old punter. Mohan, do you want to project that?
It's a pleasure to meet you, Anant. I'm meeting him after medical school. He was here junior in medical school.
Wait, you're not going to project something?
Yeah, we are projecting. So to answer or even ask the question, how you guys select patients for a particular procedure, I've seen a slide on, I've seen an article on BJU which I'm going to present. You can have a look at it and then see what you think. Another question for the panel is, with PEZ trial and POTEN trial, should we go for PAE on naive, treatment naive patients?
Treatment naive.
Yeah, the PEZ come out to say treatment naive patients also do well with the PAE rather than just starting them on medications.
Oh, prior to, okay.
Yeah.
So in the US, even though we have the American Urologic Association, the competing society is a society of BPD, benign prostatic disease. And they've actually made a really big push because of the advent of minimally invasive therapy. Right? I mean, when we did our first clinical trial for PAE, I started that study in 2009. There was no Resume, no Urolift, no Aquablation, no iTind, no Optilume. The urologic space was TURP, HOLEP. So there was a big reason for minimally invasive therapies to come in. So I think if you're going to show that BJU article, which breaks down the algorithm by size and risk factors, that's a lot of what's going on now. the stratification of patients is very much like if you want to preserve your sexual or ejaculatory function, get a mist, like a Urolift, a PAE, a Resume. But in reality, the real world data, and I know Urolift may not be as popular here as it is in the US, it's very popular, even more so than Resume. It will, those tend to have a high real world failure rate at 3 years, where TERP does not and HOLEP does not. They work at 5 to 8 years very well. So utilizing, I'd say, a practical workflow, which that article, I think, there's no slide, but it does break down clinical. It's great. So that slide I know really well because I know that British paper really well. It breaks down the workup of a BPH patient utilizing clinical factors, which the AUA guidelines do not. The NICE guidelines do not. So that one article, which was written by Klaus Rohrborn out of UT Southwestern, he basically broke it down to presence or absence of median lobe, presence or absence of anticoagulation, presence or absence of high PVR, and preservation of ejaculatory function, which is really how we should think about BPH patients. And I assume that's how you'd like to think about them too, yeah.
So we do have a size criteria. Up to 80 grams, it's TURP. 80 to 150 would be a laser. Anything beyond 150 would be robotic simple prostatectomy. And more than 500, it's prostatic artery embolization. But anyway, so some of the things, factors like a median lobe. A lot of Indian prostates are fibrotic prostates. It's not a glandular tissue that you get here. And combined with chronic prostatitis and so on, when you do a prostatic artery embolization, the outcome may not be to the patient's satisfaction. Sometimes, you know, but oftentimes we have a very good working relationship with our interventional radiologists. If I do feel they're going to benefit from a PAE, they go there straight.
Yeah,
so.
Anything else, Mohan?
Yeah, no, so again, we haven't started on treatment IU patients PAE. What's your view on it?
I mean, I think it's reasonable. That's the push in the United States where men want to have a more definitive therapy without side effects sooner, right? Because all these meds have side effects. So, and a lot of healthy young men in the United States, they don't want to take any medications. So there is a big push in the United States to get a more definitive therapy with lower side effect profile sooner.
What about Singapore? Are you pushing for?
No, we are not getting any patients from urologists. Your perspective on the treatment IU patients. Patients haven't been on any medication off the bat, straight off the bat, you do PAE.
Well, you know, when a patient walks in, the first step is going to be alpha blockers always in our practice, right? And again, it's a mind thing, you know, when a patient walks in and you say, hey, you need a procedure tomorrow, and they're out to go to the next hospital, right? So I would always, you know, there are obviously reasons where the renal function is going up and they've got multiple bladder stones, recurrent hematuria or recurrent urinary tract infections that are absolute indications for intervention. But 90% of the times they walk in, they've got some low urinary tract symptoms, and 99% of patients expect to get a tablet and then walk out, right? They don't want a procedure, they don't want any intervention, they want a tablet. And if it doesn't work, and then they're happy to go surgery. I always believe TURP or HOLEP is something, the incentive to operate should come from the patient, not from the physician or the provider, right? So the patient should ask us, do a procedure for me, I need my flow to be all right. So that's probably.
I think we can go on and on, guys. In the interest of time, we'll leave it there. Thank you very much, guys. Well done. Thank you very much.
Thank you, panelists, for the wonderful prostate artery embolization session. Now, to wrap the scientific sessions, I will be calling Dr. Ram Kishore Gurujala to give his talk about adrenal venous sampling. We welcome you to the stage, sir. Thank you, sir.
I think you all seen a literature evidence now. You can hear me, yeah? I think this is more of image-guided presentation than any literature. So I want to show what are the challenges and tricks that you encounter while doing an adrenal vein sampling. So most of the people fear when it comes to the adrenal vein sampling because the veins are so small. To get a sample from a small, like a 1 millimeter vein is always difficult. So there's various indications why you do an AVS, out of which there's so many challenges. So what with my experience for the last 10 years, I've just listed them. What are the challenges that you encounter and what are my tricks? So why is that this is challenging? Why is this a difficult procedure? As you notice, the right adrenal vein, we can't see on the CT scan all the times. We don't know exactly where it comes from. When it comes to the IVC, it's too big, or there's a large search pattern that you have to keep on searching where the adrenal veins are coming from. So the other thing is, as you don't do many, you don't know how the adrenal vein looks like. The more you do, the more different types of adrenal veins that you come across. As you can see, all these are adrenal veins, but they don't have a typical shape of V shape or whatever, the cup shape or anything. So every adrenal vein has got a different shape. Not only that, you should be aware of adjacent vessels like hepatic veins, renal veins, retroperitoneal veins, and sometimes you have to be careful of the variants like circumeiotic or retroperitoneal veins, or sometimes I see like a duplicated IVC. So you should be aware of all the variants. So I'll run through as if like I'm doing a case and how I play my tricks and everything. So imaging is the first thing. It should be a very important step. You should always look at the prior imaging, especially CT scan or MR. Then with experience, I have my rules, which I call them as self-made rules, then the tools, and then the samples. So anatomy, like this is the most important step in doing an adrenal venous sampling. If you closely look back, when you go back and try to look the right adrenal vein, I'll bet you out of 10 CT scans, you'll see where the right adrenal vein is draining into the IVC. So the first thing you need to see is what is the anatomy, how many adrenal glands are there, how many renal veins are there, and do I see an adrenal vein on the CT scan. Next one, these are the variants. You can have a duplicated, you can have a scoliosis, you can have a partially duplicated IVC, and the other common scenarios are retroaortic or circumeiotic renal veins. So rule number 0, these are base rules that I made, image assistance. Always look at the CT scan, localize what level of the lumbar vertebrae that the right adrenal vein is coming from, and you correlate your venograms when you perform that. Second one, I always fear, the first thing, why we don't get right adrenal vein sampling easily is because of the breathing. These patients on the table are breathing so excessively. To cannulate a vein while somebody is breathing is so hard. So my rule for this one is I perform this under local anesthesia. I don't give any sedation at all, so I can have some control on the breathing. Second one is there is a paper, CT evidence saying that the right adrenal vein always comes from between T11 and T12. In my experience, it's always almost like a T11 and T12 should be the location for your right adrenal vein. So this is just showing an example where the T11 and T12, T11 and T12 pedicles, not the vertebra, T11, T12 pedicles. The next rule is if you see an accessory hepatic vein, I bet that's the location of your right adrenal vein. So first try to locate the accessory hepatic vein. Once you know where the accessory hepatic vein is, if you turn posteriorly, you will get into the right adrenal vein. It's always posteriorly directed. if you angulate RAO, LAO, right adrenal vein is always posteriorly directed. Rule number 4, if I'm struggling to get into the right adrenal vein, what I do is I go to the left side and look at the anatomy. It's almost always one vertebral body above the left renal vein. It's never, one of these rules will be applicable for the right side vein. Next one, it's always projects over the kidney in all directions. This is another important trick that I always follow. So on the left side also have some rules. It drains into the left renal vein, almost always, but there is very few incidences where you see the left adrenal vein draining into the IVC directly. The rule number 2, for the left side, it's approximately 1 centimeter from the lateral margin of the vertebra. So if you pull your catheter from the left renal vein, you will fall into this left adrenal vein. In patients with scoliosis or other spine abnormalities, beware of accessory renal veins. Like in this case, as you see in the down, it's actually renal vein, and if you pull back more towards the center, you'll fall into the left adrenal vein. Rule number 3 for the left side, it's almost always opposite to the left gonadal vein. If you know where the gonadal vein is, exactly opposite is your left adrenal vein. The other tricks that you can use is during the intra-procedural, you can use the assistance of cone beam. This is very hard. With the patient breathing, the catheter might fall off, but sometimes it's better to use the cone beam CT guidance, at least to know which direction the catheter is. This is intra-procedural guidance for the right adrenal vein. So these are the tricks. Then you should understand what are the different types of right side adrenal vein that you can come across. The most common one you see across is they directly drain into the IBC. This is a common scenario that you come across. Sometimes you see they are draining into an accessory hepatic vein. This is where, once you see an hepatic vein, your vicinity of the right adrenal vein is just within 1 to 2 millimeters across the accessory hepatic vein. This is just to demonstrate, once I see the accessory hepatic vein, you just turn it posteriorly and you flip into the right adrenal vein. Just right adrenal vein. The next one, there are variants where the caudate vein and the right adrenal vein, they have a common origin. They are draining into the IVC. So you have to keep a close eye where you see a confluence drainage. Next one, this is very rare. I've seen very few cases where you have a posterior medial drainage. Caudate vein, sometimes in this case you can see there's a caudate vein, but the right adrenal vein is draining into the caudate and then it's draining into the IVC. Very rarely you'll see this variants where the right adrenal vein is also draining into the right renal vein. In these scenarios, always look for dual drainages. And in this scenario, it's directly draining into the IVC and also draining into the right renal vein. This is in literature. They say that there are sometimes you see multiple adrenal veins, but frankly, I've done hundreds of adrenal vein samplings, but I've never seen a multiple adrenal veins draining. So this is just for the literature. On the left side, it's always 1 centimeter next to the vertebral body. You can have a retroaortic. When it's a retroaortic, be careful about the paraspinal collateral veins because you might be confusing that as the left adrenal vein. Circumaortic vein is also very difficult.
Last 2 minutes.
Okay. I just have to, so duplicated IBC. So what are the complications that you can come across is a extravasation. If you get too forcible injection, you can have contrast extravasation. Believe me, within few minutes, it opens up. There are a variety of catheters that you can use. This is where the cost comes and the expertise comes. So what we used to do is we used to self-made the catheters. With time, we design our own catheters. These are named after me and my boss. They're called Ram Geisinger catheter. This is specifically made for adrenal venous samplings. The most important thing is you can cannulate, but the blood doesn't come. This is where this technique works. It's called over-the-wire technique. So we have a Y connector. We have a Heplock tubing, and I always use a transcend wire, 014 wire. Doesn't need to be any other wire, transcend wire. And some people use a side hole catheter, but I do not see any advantage of using a side hole catheter. The last one that you always you got a sample But you always have to tell the lab that this is a sample taken at a specific time, because there's a lot of contamination with contrast. Timing of the sample is very important. Transport, even in Cleveland Clinic, there are occasions the sample was lost in the transport. And coordination and communication with the clinician is very important to set up a successful AVS sampling. This is, I always call good morning when my catheter directly goes into the right adrenal vein. So this is a good morning, like most of the times, believe me or not, this is what happens. 30 minutes, you're done with the procedure. So people know that this can only be done through the groin axis. I've done a couple of cases through the neck axis. It's very hard, but maybe that's the only way to go. That's the one time you have to go for the neck side. These are the catheters. And this is just one picture showing all the rules in one patient. So left side, I'm almost done. So I'm just one vertebral body above the left side. The video is far. That's the accessory hepatic vein. That's the adrenal vein. Sorry, it comes, yeah. Okay, so one thing I learned is we should never be overconfident in AVS sampling. So because everything looks like a adrenal vein, so be careful what you are looking for. It's not hard to find. The more you do, the more experience you get and more expertise. Always look out for these accessory veins. They look exactly like an adrenal veins. Be meticulous. That's all I can do. Thank you.
Thank you for the wonderful talk, sir. Next, I would like to call Dr. Next, I would like to call Dr. Vishal Nandkishore for his talk on bladder embolization for cystitis. We welcome you, sir.
So, good afternoon. So, my talk is basically on urinary bladder embolization in the management of radiation-induced hemorrhagic cystitis. So, by definition, hemorrhagic cystitis is defined as hematuria with lower urinary tract symptoms and cystoscopic findings of urothelial damage. And one of the cause of radiation-induced is radiation therapy. So, we have to understand that radiation-induced hemorrhagic cystitis is a different pathological entity from acute radiation effects. In this, the cystoscopic findings are diffuse erythema, telangiectasias with or without ulcerations. This is a schematic diagram showing the effects of radiation on the urinary bladder epithelium. In the acute phase, there is a loss of glycosaminoglycan layer with inflammation and edema. Then comes the latent phase in which there is endarteritis and urothelial proliferation. In the last phase, there is fibroblast proliferation which leads to fibrosis, endarteritis and hemorrhage. So, there is an acute phase which lasts for weeks, latent phase which lasts for months to years, and the late phase is after many years. We come to the epidemiology and the risk factors. The incidence of radiation-induced hemorrhagic cystitis is variable. It depends upon the radiation types, the dose, fractionation schedule, and follow-up duration. The 5-year cumulative incidence is about 16%, whereas the 20 years cumulative incidence is about 10%. Prostate cancer ranks the first and then the cervical cancer to have radiation-induced hemorrhagic cystitis. Also, it has a morbidity impact on the patients in form of repeated hospitalizations, repeated blood transfusions, and other complications of the urogenital tract. This is the classification system for the radiation-induced hemorrhagic cystitis given by the European Organization for Research and Treatment of Cancer and also the Radiation Therapy Oncology Group. They have classified it into 5 categories. The first one, it consists of slight epithelial atrophy, minor telangiectasias, and microscopic hematuриas. The grade 2, it has moderate frequency, generalized telangiectasias, and intermittent macroscopic hematuриas. The grade 3 is severe frequency dysuria, generalized telangiectasias, and frequent hematuриas with reduced bladder capacity due to fibrosis. The grade 4 is necrosed and contracted bladder and severe hemorrhagic cystitis, and grade 5 is death due to hemorrhagic cystitis. So we have to understand that in grade 3 and 4, these patients typically require some more treatment than the initial conservative measures. Now, we come to the treatment algorithms. The treatment algorithm is first we have the conservative, then the minimally invasive, and last is the surgical options. In the conservative, we obviously stabilize the patient, and if blood transfusion is needed, we do it. Then comes the continuous saline bladder irrigation. We have systemic drugs, also intravesical instillation of drugs. The systemic, the pentosifine polysulfate and the pentoxifylline, whereas the intravesical we have glycosaminoglycans, hyaluronic acid, chondroitin sulfate and other agents. The most important is the hyperbaric oxygen therapy. It has the strongest evidence-based results in this category. The mechanism being the hyperoxia, it induces neovascularization, growth of the granulation tissue, and it causes vasoconstriction leading to control of bleeding. Then comes the minimally invasive, under which there is cystoscopy with or without fulguration and transarterial embolization. And the last is surgical, that is either diversion or cystectomy. Now we come to the indications for transarterial embolization. The first is refractory gross hematuria despite cystoscopy and fulguration, failure of initial conservative management, then hemodynamically unstable patient requiring rapid interventions, life-threatening hemorrhage with repeated transfusion requirement, and patients refusing for surgery. Again, I will stress that the first line is conservative, of which hyperbaric oxygen therapy is important, then comes transarterial embolization, and last is surgery. Now this slide shows the comparative effectiveness of hyperbaric oxygen, cystoscopy and TAE. The success rate for hyperbaric oxygen is about 55 to 90%. However, we have to notice that it takes 2 to 3 months for the adequate response, and the recurrence rate is about 25%. For cystoscopy with fulguration, the success rate is about 70%, but the recurrence rate is very high, 64%. Now we come to the transarterial embolization. The clinical and technical success is more than 80% and it approaches 100%. And the recurrence rate is only 10% for bilateral TAE and 25% for unilateral TAE. So all these figures are highly good. Just a brush up for the arterial supply of the urinary bladder. The bladder is supplied by the superior vesical arteries, inferior vesical arteries, vaginal and uterine arteries, and minor contributions from the obturator and the inferior gluteal arteries. Now, when to do bilateral and when to do unilateral TAE? So bilateral TAE is always preferred. We have to do angiography. If it shows bilateral abnormal supply, we have to do bilateral. There has to be a good collateral supply to prevent bladder ischemia and necrosis. For the patients who undergo first time TAE, bilateral is always preferred, and if there is a large volume hematuria, also bilateral is preferred. The success rate is more than 90%, recurrence less than 10%. We have to stop with unilateral if the anatomy limits bilateral approach. Technically, it is not feasible. Patient is having severe coagulopathy or the patient is undergoing a repeat
Last 2 minutes.
The success rate for unilateral is about 70%, but the recurrence rate is slightly high, 25%. Coming to the embolization of the agent of choice, it is PVA particles. The size is 300 to 500 microns. This has an optimal balance between the hemostasis and ischemic complications. The adverse effect, we are talking about the super selective technique. They are only minor. There has been no major morbidity or mortality reported in the meta-analysis. Minor are post-embolization syndrome and hematuria, which usually resolve. The recurrence of hematuria following TAE, it has a bimodal distribution, early recurrence occurring within 2 weeks and late recurrence occurring after approximately 4 months. So we have to follow up the patient accordingly. The follow-up, it is immediately 2 days, 2 months, 4 months and beyond 6 months. And I want to stress that cystoscopy is not routinely required in all patients. We have to do cystoscopically only if the patient develops a recurrent hematuria or has a new complication. Cystoscopy is not routine. The Canadian Urological Association has given some guidelines for the initial management. They say that at least one cystoscopy is necessary with biopsy to prove whether it's a malignancy or not. On embolization, they have stressed that superselective embolization is a treatment of choice when the conservative management fails, and also we have to go for superselective embolization. And surgery, it should be reserved only for refractory cases, and also the patients and clinicians should be aware that it has a high morbidity and mortality. There are some knowledge gaps. More research is needed in this topic. The follow-up is short. We have to have more than 5 years follow-up. And also, we have to study about the cost-effective analysis, which will definitely prove TIE is superior over hyperbaric oxygen therapy. Just one case I will show. This was a case of carcinoma cervix, operated, received chemoradiation, presented to us with refractory hematuria. You can see the clot, and this was a vesical artery which was abnormal. This is the angiogram. Okay,
Time is up.
So I have this images. We can see that this is the angiogram of the anterior division of the internal iliac artery. This is the abnormal vesical artery which is showing the blush. We have a microcatheter in this. This is the abnormal blush. We embolized it and patient improved within 48 hours. So take home message, super selective TAE, good clinical success, very less minor complications, bilateral approach preferred, embolic agent PVA 300 to 500 microns, and cystoscopy is not routinely indicated. And preserve collaterals to prevent bladder ischemia. Thank you.
Thank you, sir. I would like to call upon Dr. Ajay Alex for his talk on benign renal lesion embolization, AML, APKD.
So good morning to all of you. I know after 3 days of academics, all our attention span would have been embolized, and I assure that we would be, I'll keep it short with this embolization for benign renal lesions with special emphasis on angiomyolipomas and polycystic kidney disease. Right. So what is the rationale behind proceeding with embolization for renal benign lesions? One is obviously to stop bleeding from these lesions. The second is when they are very large, you need to reduce the size of the lesion in order to reduce the compressive symptoms caused due to the lesion. Also, if you want to avoid a surgery wherein you want to preserve renal parenchyma, embolization may be the option that can be considered, in addition to very rarely even pre-op embolization to reduce blood flow to these benign lesions. We'll start with angiomyolipoma spectrum. So this was a 46-year-old male with left flank pain, hematuria with imaging revealing angiomyolipomas. This was the angiomyolipoma that was protruding into the pelvic ileal system, causing the hematuria. So when it comes to angiomyolipomas, you do cross-sectional imaging, either CT or MRI, depending upon the operator's choice. You need to do clinical evaluation to rule out whether there is any syndromic disorder that's underlying, especially tuberous sclerosis. Now, if it's symptomatic, whatever be the symptoms, treatment is warranted, wherein surgery or endovascular are options that can be considered. Largely now it's being done with angioembolization for these lesions. Now the problem arises when it's asymptomatic, when to treat an asymptomatic angiomyolipoma. Now there are few predictors that you need to identify that are high risk for bleeds and that warrant an embolization at least for treatment. So now it's understood that a size more than 4 centimeter for a sporadic angiomyolipoma and a size more than 3.5 centimeter for a syndromic one are high risk for bleeding. Also, if there is intralesional aneurysms, that's more than 5 mm, a female sex with pregnancy because of higher estrogen levels are markers for high risk for bleeding. In addition to elevation in or more the content of angiomyogenic component compared to the fatty component within the lesion is an indicator that you better off doing an angioembolization for preventing bleeding. Now, what is the embolic agent of choice? It's controversial as per literature, but generally any permanent embolic agent, especially PVA, or nowadays most operators have shifted to glue as one of the preferred agent because of the longevity of the embolization. So this was a patient that was taken up for angiogram. So this is the Cobra catheter. You go selectively to the feeder artery and then we embolize with PVA particles at 250 to 350 micron size. This was another angiomyolipoma, relatively small in size, but an aneurysm was seen within, which was bleeding, causing the Wunderlich syndrome that was coiled off along with glue to occlude the aneurysm within the angiomyolipoma. Now, this was a lesion in a 42-year-old female, a large lesion within the left kidney, right from the subdiaphragmatic lesion area, extending till the mid-renal level in this particular female. Again, we angioembolize the same, catheterize the feeder specifically to embolize the same with PVA particles. So the important factor that you see in these lesions is that much more than the size reduction of these tumors is the density within the tumor. So generally if you have angiomyogenic component, the longevity of the embolization procedure in your follow-up would be much better if you have replacement of the angiomyogenic component with fatty metaplasia within the tissue, as has happened in this particular case that we embolized. Also, this was another female who was planning pregnancy in the reproductive age, incidentally detected large angiomyolipoma with angiomyogenic component here that was embolized selectively with PVA particles. As I said, now we have also shifted back to using glue as one of the agents because of the longevity as well the permanent nature of the embolic agent, as is the literature that shows coming out from the Western world as well. So this was one where the feeder was embolized with glue. Now we move on to a relatively rarer spectrum, especially in our part of the world where embolization for polycystic kidney disease, where it actually plays a role. So generally we know that we embolize wherever there is bleeding, but when it comes to polycystic kidney diseases where you have progressive renal enlargement, sometimes hematuria, mass effect, that all affects the quality of life, embolization is something that can be considered in this subset of patients. Now generally what is presently being done is largely conservative or medical management for these patients. And in patients, if they are having significant symptoms, surgical nephrectomy is considered. The risk for perioperative morbidity and mortality is something that is always kept in mind. Now, interestingly, if you see, these renal arterial branches in a polycystic kidney are never atrophied, unlike a renal atrophy. Though even if parenchyma is not there, the renal arteries are actually very relatively good size. So the pathology actually says that there is increased vascularity to that kidney, and it is the increased vascularity to the cyst wall that causes enlargement of the cyst progressively at about 5 to 6% every year. And that's why we now have a thought process that if you embolize the renal arteries with your interventional radiological techniques, you can cause cyst involution by inducing ischemia in this. So the actual indication is basically in any symptomatic enlarged kidneys. So enlargement just means that in your CT, if the kidneys are enlarged below the iliac crest level, failing in order for size reduction, you can always do this procedure. So pre-transplant volume reduction, because the extraperitoneal space may not be adequate when the kidneys are very large. So you want to reduce the size of the kidney, this may be the procedure that can be done. Even in poor surgical candidates and who fail conservative therapy, this is something that can be considered. So you need to ensure that there is no residual function in these kidneys and a cross-sectional imaging to map out your renal arterial anatomy. Obviously, you need to get your nephrologist and transplant surgeon on board. You can do unilateral, bilateral depending upon the requirement. Selective, super selective is not specifically being hold to said any advantage. Embolic agent as well, generally preferable to use a permanent embolic agent. You can do either a single or a staged embolization. Volume reduction is nearly 40% as is seen in this case at about 1 year, with symptom relief in more than 90%, even pulmonary function improvement as well, in addition to quality of life and facilitation of renal transplant. Poor outcomes means that you have a thick cyst with calcification is generally not a good thing. So in short, TAE is a good option in benign renal lesion treatment if you select the patient correctly with meaningful symptom relief, and obviously you need to get your nephrologist and your transplant surgeon on board for these. Thank you.
We have come to the final talk of the session. I would like to call upon Dr. Nilu for her talk on undilated PCN, antegrade and retrograde stent. Welcome you.
So finally the last talk. So non-dilated PCN basically maybe, and not maybe non-dilated, but nephrostomy may be an everyday procedure for most of us, and stenting also. But non-dilated system can be challenging, where you have to basically understand when to pause, when to actually proceed or change strategies. And definitely I'm going to talk about the tips and the tricks which we need in a non-dilated system so that it becomes more of a controlled procedure rather than luck. So I've divided into non-dilated system, ureteric stenting, then we'll go on to rendezvous technique, and then some niche cases. Indications, I'll just quickly go through them. Ureteral transactions is the commonest, most likely iatrogenic and sometimes traumatic. Fistulas and leak are the next. The absolute contraindication is coagulopathy, and relative contraindications are very many. I generally use ultrasound guidance in plain technique. Sometimes we use fluoro guidance. Written informed consent is a must. Pre-procedure antibiotic, we generally give ceftriaxone or amikacin, but everybody has their local advice. Coagulation study is a must because we know that septic patients may have coagulopathy. We follow CERSIS standards of practice for perioperative anticoagulation guidance. Always do a WHO checklist, and sedation though not essential, but it should be considered very useful, especially in anxious patients where they are breathing really, really heavy. Prone position is required unless the patient has some problems like spine or pregnancy, or they have colostomy where they cannot lie prone. So knowing the anatomy in a non-dilated system is very useful. I generally tend to look for the renal pyramid and go and target the renal papilla. Why? Because the renal papilla is actually the GPS for the collecting system. So once you're inside the collecting system, I generally tend to leave the needle free, moving with the breathing. So, and I don't try to catch it because the tip is just about in the collecting system. So any catching will actually displace the tip. And to wire it, I simply ask the patient to hold their breath. So there are multiple tricks to actually help through the non-dilated system. First is IV fluids, often help while scanning or at the start of the case. Injection of IV contrast when you're trying to do fluoro-guided, so only 50 mL is usually sufficient to basically opacify the pelvic ileal system under fluoroscopy, but it is time limited. Furosemide is actually a magic drug. Why? It is neither contraindicated nor toxic. 20 to 40 milligrams with 250 mL of saline bolus is usually sufficient, acts immediately, and you can increase up to 60 milligrams. There are only two things which you need to be careful about furosemide. First is in prone position, when you go up to 60 milligram, it can cause hypotension. The other thing is furosemide may not act when there is a large ureteric leak. Always use small ureteric needle, that's basic common sense. And yes, rely on ultrasound as much as possible before probing with a wire. There's another technique called double puncture, like PTC-like technique, where you can use either an 18 gauge or a 21 gauge needle where you try to puncture the renal pelvis under ultrasound or fluoroscopy. I usually, if I don't see anything, I just go straight PA approach, 2 centimeter lateral to the transverse process of L1, L2, and then, or either target a stone or a stent. Once urine is obtained, tend to use dilute contrast because any neat contrast will stain the system. And if the urine is not obtained, then obviously redirect the needle and go through like a PTC. Occasionally it is possible that you enter a renal vein, but that's good because you are actually near the collecting system, and any angling will actually, with the wire and the needle, will lead you to collecting system. Once you're in the collecting system, or you think you're in the collecting system, please confirm, because sometimes it's possible to be in one of the gonadal veins or a branch of a renal vein. Second needle can be used to actually puncture the calyx if you're in the pelvis. We rarely use our urology colleague to do a retrograde injection, so, but it is a technique which can be used. This is an example of a PTC-like technique where you'd use. So this is a lower calyx puncture. This is just to show that you get you should get your wire down to the ureter. I don't know okay, this thing is not working. And when you use a lower calyx puncture, there's an acute angle. So if you have to do a ureteric stenting, I tend to puncture the middle calyx or the upper calyx. I think it's a video to show that. Try to go into the ureter, but it didn't. So put a large, long wire into the upper calyx, and then the 3-piece actually should be done under vision, because the tricky angle is difficult to negotiate at times. And this is the DC. So this is a very interesting device which we use because nephrostomy in a non-dilated system is a very precious thing. So this is a relink device. It actually works like a seat belt. So when there is a pull or a large thrust, somebody really moves, this actually detaches itself, and it's a valved device. It's very, very inexpensive, and it's actually a savior. So ureteric stenting, so it's very important to choose the right size, 6 French or almost time.
Last
so
2 minutes.
Fine, I'll just won't go into details, so then probably. So, so there are multiple techniques where, you know, you can form your own string to use it as a push-pull technique, and that will give you a lot of pulling thrust in an antegrade stent. So we usually tend to form our own string in the ureteric stent, but the only thing about this is it can cause a kink, but it is rarely possible to cause a kink like this. But forming your own string helps to give you a lot of pull in a push-pull technique. So this is a crossing. I think I'm actually really short of time, and there's a lot of presentation left. So we tend to sometimes use a sheath, a vascular sheath, or a peel-away sheath for support, and then I would just like to skip all of this. So this is a ureteric stenting with a ileal conduit in a neobladder. A nephroureterostomy, it's like an internal-external drain. And these are the rendezvous technique is basically meeting in the middle, where sometimes you have to meet in the middle in the ureter, in the collection, or sometimes in the ileal conduit or in the bladder. So this was a very tortuous ureter, and we snared it and held it in position in the bladder. And then we put it, because the stent wasn't going through, so we had to actually stretch it with a snare. This was a horseshoe kidney where we had through and through technique, where we pulled out from both sides and then finally managed the stent. We only use the urological lead when we have to cross the VUJ, and then you do it in the middle where you have to balloon dilate and put in a stent. We also do some metal stent insertions for malignant lesions, and snares to remove the antegrade stent, modified and simple snare techniques. We can also do antegrade metal stent removals by using the modified and double stent technique. And lastly, I would say that we can do ureteral embolizations, especially in cases where there is vesicovaginal fistula or a vesicorectal fistula. We can use a plug, coil and glue. Thank you.
That brings us to the end of the scientific sessions. Can I please call upon the speakers for a group photo, please? Dr. Nilu ma'am, Dr. Ajay Alex sir, Dr. Nand Kishore sir, and Dr. Ram sir, please, if he's here. The center, sir. Thank you, speakers, for the wonderful session, and thank you, audience, for being such a good listeners, such good listeners. So that brings us to the end of the session. Kindly join us at the Oceanic Hall for the validatory function, please.